Uh, Thank you, Neha madam. On behalf of Team IMA Nagpur, we welcome you for the most prestigious 19th NIMACON of IMA Nagpur. Today's workshop on fire, TB, CPR will add more knowledge to our knowledge bags. Today is the death anniversary of our beloved great teacher, Dr. B.S. Chaubey sir. We dedicate this workshop to his memory. Jai Hind, Jai IMA. Thank you.
Thank you, Devtale sir. Now I would like to invite Dr. Sachin Gathe, Secretary of IMA, Dr. Shehnaz Chimthanwala Madam for Dr. Shehnaz Chimthanwala Madam, Organizing Chairman of NIMACON, Dr. Manjusha Giri Madam, for Secretary of NIMACON, Dr. Prashant Nikhare Sir, Scientific Chairman, and our guests today are Dr. Anil Ladda, renowned ophthalmologist and MMC member. Another guest, eminent pediatrician and Vice President of Maharashtra Medical Counseling, Dr. Vinky Ragwani Sir, and Assistant Professor, State Institute of Health and Family Welfare, Dr. Sanjay Chilkar Sir. Yes. I invite them to come in front for lighting of Samai. We also call upon Dr. Dhakre Madam, Chairperson IMA MS. So I would like to invite Dr. Devtale sir to welcome Dr. Laddat sir with a memento. I would like Devtale sir to welcome Dr. Vinky Ragwani with a floral bouquet. I would like Devtale sir to welcome Dr. Sanjay Chilkar sir. Thank you, everybody. Please have a seat. A sudden catastrophe that causes a great damage or loss of life is a disaster. So today's first session is on disaster management of fire. For this session, I would like to invite our chairpersons, Senior Pulmonologist and Chairman, KRIMS Hospital, President of Vidarbha Hospital Association, Dr. Ashok Arbat, sir. And Secretary of Vidarbha Hospital Association and eminent orthopedic surgeon, Dr.
We start. Good afternoon, everybody. So today we will be discussing disaster management, and I suppose this is very important for everybody of us, because we might have seen now during COVID period, many fire disasters have happened, and ultimately we have to rectify the things. We have to see that it will never happen, or we can minimize the damage. So for this fire session, we have got eminent speaker, Dr. Shailesh Gahukar, who is the Administrator, GMC and Super Specialty Hospital, Nagpur. He has done his MBBS and MD from GMC Nagpur and second MD in Hospital Administration with distinction from PGIM Chandigarh, and was a topper. He has also done his MBA in Hospital Management from Coimbatore University, postgraduate diploma in Medical Legal Systems from Symbiosis, Pune, and he is trained in Lean Six Sigma. He has 6 national publications and is also working on the Seaboard ICMR project. He has 2 patents in his name. And without spending much time, I will invite Dr. Shailesh to deliver his first lecture on fire session, which is under the disaster management. Thank you very much.
Thank you, sir. Thank you, sir, for the candid introduction. Very good afternoon, dignitaries on and off the dais, and all delegates who have joined in today. I thank IMA organizer who chose to start prestigious NIMACON with such a need of an hour and a burning topic today. It's my privilege to be the speaker to talk on such an important topic. These are few newspaper articles. It was on 6th November 2021 when 11 COVID patients were killed in Ahmednagar hospital fire. 10th November, it was repeated in Bhopal. And in Bhopal, Ahmednagar, and as many as 24 cases of hospital fire India has witnessed in last 1 year. More than 100 people have died in such incidents. There is a sudden surge of fire incidents in hospital, and main culprit being electrical short circuits. So these fire and electrical incidents are avoidable disasters, and it's high time to act upon. Honorable Supreme Court has also taken the cognizance of these fire incidents and has directed all states to conduct fire safety audits of the hospital across the country. And on 19th of July this year, they had directed all hospitals to comply with fire norms or else shut down the establishments. Accordingly, all government machinery has charged to get this hospital fire compliant. So this is a copy of Government of India letter to all chief secretaries in this regard. So we don't have choice now, but we have to comply, and we need to do, and we need to act immediately. So what are the acts which are applicable to fire safety? In Maharashtra, this Maharashtra Fire Prevention and Life Safety Measure Act of 2006, which was notified on 5th Feb 2007, and rules were notified on 23rd June 2009. Act was amended last on 2015. Apart from Act, there are National Building Code Part 4, which is applicable to fire safety. And as per the recent amendment, they have also included National Fire Protection Association norms of USA. First and foremost question which comes to our mind is this act applicable to existing buildings? The answer is yes. As per the order of Honorable Supreme Court, High Court in PIL 107 of 2013, the act is applicable to all existing buildings. So para 13 of the order says the building which are existing or building which are under construction, the owner thereof would be required to undertake and carry out such additional fire prevention and life safety measures if notice is served upon him under Section 6 of said Act. So it is obvious that it is applicable to all establishments. So what is key provisions of this Act? Section 2 of the Act defines fire prevention and life safety measures. It should be in accordance with the building bylaws. Currently in Nagpur and Maharashtra, it is UDPCR 2020, National Building Code of 2005, and recent is 2016, and National Fire Protection Association Institution norms of USA. Act defined occupier as tenant, owner, a rent-free tenant of any land or building, a licensee in occupation of any land or building. So occupier is very important. Means any building, you are a tenant or a owner, you are occupier of that building. Then a license agency. License agency means a person or association of persons licensed by the director, Maharashtra Fire Service, or chief fire officer for executing fire prevention and life safety measures. Most important is Section 3 of 1. It says the owner or the occupier of building shall provide minimum firefighting installations in the building as specified in Schedule 1. So what is Schedule 1 of Act? Schedule 1 is a table which contains classification of building, type of installation, how much water supply you require, and how much pump capacity is required. This is the relevant part of Schedule 1, where hospital is classified under Group C, Subdivision 1 as institutional building. So you have handouts which have Schedule 1 in it. It actually is a NBC Table 7. So we have to read this Schedule 1 and also Table 7 of NBC. You can refer that. Required type of installation is shown as R, and not required as is shown as NR. Now, most of us have the impression that fire extinguishers are only required in hospital and we comply with the fire norms. So you can see here, fire extinguisher is just a part of it. And there are so many things we need to comply. So these are commonly known fire extinguishers, and there are 4 types. First is water type. Second is dry chemical powder, which contains mono aluminum sulfate. Then it is other is CO2 and foam. We are going to demonstrate this in our fire drill after this session. So let's see what norms are for G+1 hospital. So if you have a G+1 hospital, So you require a fire extinguisher. You can refer your handouts. So it would be easy for you. So for G+1 hospital, fire extinguishers are required. Hose reel systems is required. Your downcomer is required. Automatic sprinkler, they have given us C note 2. If there is a basement of more than 200 square meter, only automatic sprinklers are required, or else you will not require automatic sprinklers. You will require a manual operated electric fire system, a terrace tank of 5,000 liter, and a pump or booster pump of 450 capacity. So how much is 5,000 liter tank is just for illustration, it is a 5 feet by 8 feet tank and height is of 5 feet. So you can have 5,000 liter of water in it. If your hospital is more than one floor, G+1 floor, that is G+2 hospital, but it is less than 15 meters, then the norm changed. You will require fire extinguisher, hose reels, but here you require the wet risers, and you will require the underground tank of 50,000 liter. You will require a 5,000 liter tank above your terrace, and you will require automatic sprinklers now. Above 15 meter, but less than 24 meters, the requirement will be same, but underground tank would increase from 50,000 to 75,000 liter. Terrace tank will be of 10,000 liter, and pump set will increase. There will be a diesel pump, main pump, and jockey pump will be required. You have to prepare such fire plans to derive quantity and cost of how much it would require. Previously, hospitals were given sanction till 30 meters. Now, as per the amendment, they have increased the height of the hospital and more height can be constructed. And these are the norms for the hospital where everything is required as per more than 15 meters. Only water supply tanks and pump capacity increases. And additional norms of NFPA is required. Now, most of us has the hospitals in mixed occupancy buildings. So what in case you are in the mixed occupancy and there is residential, commercial, and hospital activity in the hospital. So I am taking the case that hospital A is on ground floor. It will require the norms of G+1. If it is on second floor, it will require the norms of G+2. And if it is on fifth floor, it is more than 15 meters. But the complete building should also be fire compliant. But if it is not so, but your hospital should be fire compliant as per the norms. Apart from non-structural elements of fire safety, you should have structural element in place. Like you should have an open space, like side margin should be 6 meters from, it is minimum 6 meters from all sides. As the height increases, it also increases. And means of escape should be continuous and unobstructed. Internal staircase, minimum width should be 2 meters. External staircase should be closed and it should be fire resistant. And self-opening door should be there and fire door should be there. You should have a exit door of minimum 2 hours rating. Corridor and passageway should be 2.4 meters and there should be proper compartmentation in the hospital. These are few structural elements. There are many which can be referred from NBC Part 4. There should be a proper signage in the hospital. Like there should be fire escape plan. Where is the assembly point? Where is the fire exit doors and fire orders properly displayed in the hospital. Moving to section 3, it says without fire compliance, building plan cannot be sanctioned by any authority. So you have to get your building plan sanctioned after you get the NOC from provisional NOC from fire department. So this is important, Form A and Form B. Everybody is like, what is Form A and Form B? It is under section 3 of 3. There are 2 forms which are made mandatory. It is Form A, which is issued by the license agency regarding the compliance to the regarding completion of the work, and it is a compliance report given to Chief Fire Officer by the license agency. And Form B, it is a maintenance report, which is issued twice a year in month of Jan and July with requisite fee to fire office. There is a provision of imposition of fee. You have schedule 2 with you. So as per the square feet area, they have given the how much fee will be levied on the building project. And this is schedule 2, but it is subjected to minimum rate. Like you have 5 rupees square meter rate, but you have to pay 30,000. If it is less, demand is less, but you have to pay 30,000. So that is the minimum what is prescribed. Similarly, in section 12, there is a provision of imposition of annual fee, which is at the rate of 1% of minimum fee specified in respective columns. So if it is 30,000, you have to pay 300 rupees per annum to chief of fire officer. This fees can be reduced or enhanced anytime with proper notice. Section 4 of the Act says assessment and collection of fee. Now, this is important. You have to pay what you occupy. You don't have to pay for a whole building. If you are occupying 1,000 square feet, you have to pay for 1,000 square feet only. And if you are not paying the fees in time, there's a provision of charging interest that is at the rate of 18% per annum. Next is how we can get our compliance certificate or NOC from fire department. First of all, we have to appoint a license agency. They will do the fire safety audit. They'll prepare fire plans. They will execute the work as per the fire plan. If they will give you Form A, and that has to be submitted to the fire department. They will raise the demand. That has been forwarded to inspect fire department, and the inspector will inspect your premises, and you will be given fire NOC or compliance certificate. Once compliance is done, fire chapter will end. But if not, fire chapter may start. So what is the other sections? Section 5 says, Section 5 give fire officer power to inspect any building by giving 3-hour notice to occupier or owner. All assistance has to be provided during inspection, and no one should obstruct the inspection. Doing so is offense under the Act. Under Section 6, fire officer will note the inadequacy or non-compliance and issue a notice to the owner or occupier, directing him to undertake such measures within specified time, and it is usually 120 days. If Section 6 notice is not complied, fire officer may serve notice under Section 8, Clause 1. And it says to vacate the premise immediately because it is not fire safe. The premises is not fire safe. If it is not done within stipulated period, they can initiate action under Clause 2A and disconnect water and electricity. Or further, they can ask police to remove such persons from the premises. If it is not done, they have the power to seal your building or part thereof. And once sealed, no one except the director or fire officer has the power to remove the seal. There are few punishment provisions, and under Section 36, it is with rigorous imprisonment from 6 months to 3 years, fine of rupees 20,000 to 50,000, and where offenses is continuing, then there are provision of 3,000 per day till the offense continues. If you get notice under Section 8, the procedure is same. You have to process the same. You have to follow the same process and get your certificate done. If you don't want certificates, you can just submit Form A, and further proceedings from the department will be stopped. If you get the Section 8 notice, and if you comply with this and provide Form A to the department, they will stop the proceedings. So why compliance is required? Fire compliance is very important legal compliance, as it is required to get your registration, NABH, and of course, insurance. So I request you all to get it done and have peace of mind. Believe me, it will give you some immunity as you have received with COVID vaccine. So last but not the least, remember, preventing fire is better than fighting fire. So please be safe by choice, not by chance. Thank you. In case of any query, you need any help for disaster hospital management, you can call me. Thank you.
Thanks, Dr. Shailesh Gaukar, for giving a extensive idea about the implementation of the fire devices at the institution and what are the legal implications of it. So that I think it is a quite educative for all of us, because many times we are facing the situations, and once the disaster happens, then we have to face the complications. So thank you very much. This session is open for any question answer. Any question from the audience? Yeah, please.
Sir, mine is not a question, but it's a point to ponder. You see, whatever the incidents, I'm specifically talking about the Maharashtra. Some have occurred, nearby us in Bandara or, Nagar, all these hospitals. I'm talking specifically of government hospital. Let's not talk about the private nursing homes or hospitals, because there are spectrum. And, sometimes it may not be feasible or plausible for those hospitals to do such extensive fire prevention, which is necessary. Now, when we talk about the government hospital, it is the doctors who are suspended. We are actually the custodian of the hospital, and the people who are supposed to maintain or supposed to put up these projects are never suspended, like PWD or other people. So these doctors also have to, project, and specifically our association like IMA, and most of these doctors are members of IMA. And when they are suspended, we are the mute spectator. We sometimes just make few noises here and there and then keep quiet. Do you agree? This is just point to ponder over. Thank you.
I think IMA president can highlight these things.
Thank you very much, sir, for the concerns which we have shown. We have incidents, you told Bhandara and Nagar. It's the effort of the IMA which has caused release of the medical officers and nurses at Bhandara. And also it is the pressure and efforts of the IMA which caused to release also the doctors and nurses at the Nagar today. So this is the teamwork which IMA is doing for these members. We are not seeing whether that person is a member of IMA or not. They are basically a healthcare worker, and we are a healthcare worker. We got minimum training of the fire. We are not fire officers. So this is a wrong policy of the government just to specify, to suppress the things. सबसे बड़ा target रहता है doctors and nurses. You have not seen single person from PWD or other department to be suspended or arrested. It's only because we are not united. We have to be united. We have to build a pressure on the government that it is not our responsibility to maintain all these things. So this is what I think is the we should have united for such incidences. अगर इसके बाद अगर ऐसे कुछ incidences हुए तो we will not tolerate arresting doctors or nurses.
Criminal cases have been filed against this doctor. You say you have helped them to release. This is a half truth. Those doctors are still suspended since last so many months or years. Now, you see, that is a different point of view. Once the case is against you, the government has, they have to suspend you. But then why the only doctors? Do they manage the buildings? Do they look after the building or maintain the building? This is solely responsibility of the government. You know, if you go into the details, the most of the time, the projects like fire prevention projects are lying with the government. And the secretaries and other government dignitaries have not taken any cognizance of this projects. So what has happened to them? This is actually purposefully suppressed.
I think whole house will be agree for this. This is totally injustice toward the doctors and nurses because they are not the people who are looking at the government hospital at the fire. Basically, it is a concerned department has to look, and I think this needs some challenge through laws only. That can be solution. I think so.
But sir, sorry, I'm Dr. Dongre. Sir, but at once they are being held with the criminal charges. They are criminal. They have the intention to kill the patients. No, even that is the big question. They might be suspended. They might be taken away from the work sites. It's okay. They are held away. Doctors or the health workers are kept away. But filing the criminal cases as if they are the murderers. Is it so? No, sir. We are not the criminals. We are not the person bound to kill our patients. And so why the criminal cases?
So the answer lies in the question itself. It is to create noise.
Yeah.
So the government is creating noise and
But-
we have to stop it.
That is what we need. We must get united. And as sir said, very mutely we are just pushing them. The day one we have raised the voice and then we kept. No, sir, there should be really one team from our side, not only from the IMA Nagpur, but our Indian locality from the health workers. There should be a team that they will force, they will praise, they will take this matter for the governments. Number one. And number two, as sir said, there was one wild discussion. अगर किसी बिल्डिंग में अपना हॉस्पिटल है तो अपने फायर सेफ्टी देखना जरूरी है एट लीस्ट दिस इज आई एम सॉरी बट आई एम अगेंस्ट दिस नंबर वन मेरा हॉस्पिटल अगर किसी बिल्डिंग में है तो आई शुड टेक केयर ऑफ माय हॉस्पिटल्स फायर सेफ्टी लेकिन आजू बाजू से जब अंगार लगेगी तो मेरी फायर सेफ्टी तो अब क्वेश्चनेबल हो जाएगी ना सर मेरी फायर सेफ्टी तो क्वेश्चनेबल हो जाएगी तो मुझे उस हॉस्पिटल में बिफोर मेकिंग माय हॉस्पिटल इनटू दैट बिल्डिंग the age of that wiring, age of that building, age of that construction, age of that infrastructures, which may damage my infrastructure, which I built up on my new phase. ये होना जरूरी है सर. If I am wrong, sorry sir. Thank you.
Okay, sir is here.
Thank you sir. Thank you. Sorry. But it is not being highlighted, and the people like sir said, we are unknown.
Sir, these are the news which does not create sensations, and that is one of the reasons.
That is what the reason we need to create the sensations to. Owner. We are not the occupier, not the owner.
Occupier, we are not custodian.
Even, sir, I agree with you. We are not even the custodian. After 8 hours or 10 hours or 12 hours, we are just going. Another guy comes over and takes the charge.
Sir will answer in his lecture.
Thank you, sir.
Thank you.
Thank you for extensive discussion on this important issue. And I thanks Dr. Gokar for his excellent deliberation over the fire. And we'll go for the next session.
For the next session, I would like to invite my close friend, Mr. Rajendra Uchke. He is a divisional officer and holds an additional charge of a chief fire officer at Fire and Emergency Services, Nagpur Municipal Corporation. And so many queries are there in line for him, so it will be difficult for him to answer all these queries. In field of fire service, he is since 1991 and an alumni of National Fire Service College, Nagpur. This is a prestigious institute in Nagpur. He has passed his sub-office course, station officer course, and was a gold medalist in divisional officers course. That is an advanced diploma in fire engineering. Mind you, this is very few people in India have done this. He has worked with Reliance Industries since last 11 years. So welcome, Mr. Rajendra.
Good afternoon, everyone. I take this opportunity to thank the IMA officials for inviting me and choosing such an important topic. And I was surprised to see the kind of presentation Dr. Gahukar has just given to all of us. He has done a lot of research work, and I think he's the one doctor who has understood the Fire Act completely. So instead of coming to the fire department first, you can approach your own fraternity person. Now this fire safety topic being an important subject at present, so many incidents we have seen happening in Maharashtra, in India, and also abroad, because there were many temporary COVID care centers and hospitals which were constructed of combustible materials, and due to temporary electrical fittings, many hospitals were burnt out and there were so many casualties. So this fire safety topic has become of immense importance. Earlier, the doctor fraternity used to say कि मेरा hospital में तो extinguisher लगा है. I have taken all the precautions. Lekin let me tell you, this is a very vast subject. Fire safety begins right from the planning stage of that building. There are so many norms, so many conditions for any building which comes up. It has its own design criteria, and hospital is one of the most vulnerable building for which the architect and the civil engineer should understand the requirement of that particular occupancy. For this, the architect and the town planners or the civil engineers who are granting sanctions to the hospitals, they should understand the requirement of that particular occupancy. The staircase width cannot be less than 2 meters. The doors width cannot be less than 2 meters. The side marginal spaces for the movement of the fire appliances should be 9 meters. So there are many such occupancy wise requirement of that site and the construction designs which needs to be considered at a very early stage. जो नागपुर में या बाकी पुराने cities में scene है कि already the building is constructed for some other purpose, then वो commercial space doctor purchase करते हैं और then that commercial space is converted into an hospital. So it is very difficult to comply all the structural norms required in that hospital, and then the NOC part comes. So NOC as a document है we have to check that each and every condition of the National Building Code or the Development Control Rule is complied, and then only the NOC can be granted. Now, my Fire Act speaks about only the firefighting measures required, that is enlisted in Schedule 1, as Mr. Gahukar has already covered that topic. So, structural requirement और वो प्लॉट का साइज नागपुर जैसे शहर में मिलना और देन फाइनेंशियली वो फिजिबल होके वो हॉस्पिटल का बनना, तो दिस इज अ वेरी डिफिकल्ट टास्क वी आर फेसिंग. हम लोगों के पास जो भी प्रपोजल आते हैं तो सभी में यही रहता है कि साइड मार्जिन 6 मीटर की तो दे ही नहीं सकते. अगर 6 मीटर साइड मार्जिन अगर छोड़ते हैं तो डॉक्टर उमरे जी ने अभी अभी एक प्रोजेक्ट पे काम किया है और उनको इस चीज का अंदाजा है कि लोकेशन ऑफ द स्टेयर केसेस and side marginal space ये बहुत मुश्किल है छोटे प्लॉट्स में एक हॉस्पिटल या इंस्टीट्यूशनल बिल्डिंग को कंस्ट्रक्ट करने के लिए. एंड नाउ आफ्टर दिस न्यू UDCPR, the FSI is increased and you can go again 2-3 floors more than your sanction height. तो और हाइट बढ़ेगी, वही साइड मार्जिन रहेगी, और ऐसे स्थिति में जो चैलेंजेस है फायर डिपार्टमेंट के सामने वो बहुत बढ़ गए हैं. और वी आर एक्सपेक्टेड कि हम लोग जाने के बाद कितनी भी कैसे सिचुएशन हो, यू हैव टू सेव द पेशेंट्स और वी हैव टू सेव दोज पर्सन हु आर स्टक अप इन द बिल्डिंग. तो ये चैलेंजेस को फायर डिपार्टमेंट अपने नजरिए से देख रहा है. जो बिल्डर्स और डेवलपर्स है या जो इन्वेस्टर है वो अपने नजर से देख रहा है. सब अपना अपना उसमें ज्यादा से ज्यादा शेयर लेना चाहते हैं. लेकिन जो डिफिकल्टीज अल्टीमेटली फेस होने वाली है वो फायर डिपार्टमेंट को होने वाली है, क्योंकि वाइल ग्रांटिंग अप्रूवल ही विल बी हेल्ड रिस्पॉन्सिबल कि आपने उसको परमिशन दी थी, वहां वो इंसिडेंट हुआ है और वहां पर फायर व्हीकल्स को अप्रोच करने के लिए भी जगह नहीं थी, फिर आपने उसको 6 की जगह 4.5 में कैसे अप्रोच दिया. तो जब ये इंक्वायरीज बैठती है और सब होता है तो ये सारे जो लीगल पॉइंट्स है ये सामने आते हैं, और वो जो रिटायर्ड जज होता है वो सिर्फ यही देखता है कायदा क्या बोल रहा था और उसका पालन हुआ या नहीं हुआ. इतना सिंपल है. और आप दोषी है और आपके ऊपर सदोष मनुष्य वधाता गुना वगैरह और जो भी सारे लाद के आपको सालों तक के कोर्ट में केस और अपने आप को बचाने के लिए छोड़ दिया जाता है. तो ये प्रेशर फायर डिपार्टमेंट में भी है. आपको बताता हूं कि जो भी इंसिडेंट VRs में होता है आफ्टर 12 to 4 o'clock, वो फायर इंसिडेंट हम लोग रिपोर्ट भी नहीं करते. हम लोग अपनी पीठ थपथपा सकते हैं कि वी हैव डन सच अ लॉट ऑफ गुड वर्क इन दैट फायर, वी हैव सेव्ड सो मच लाइफ. लेकिन हम लोगों को नहीं चाहिए, क्योंकि जैसी पेपर में वो न्यूज आती है उसका LAQ अगले अधिवेशन में आ जाता है. फिर उसमें सारा ये आता है कि इस बिल्डिंग को NOC थी या नहीं थी, फिर आप कब गए थे, आप जाने के बाद फिर फायर लगी, आप उसमें जैसा उन्होंने बताया कि 120 दिनों का ही मैक्सिमम नोटिस दिया जा सकता है. तो आप 140 दिन तक के नहीं गए. अगर आप टाइमली एक्शन लेते थे तो शायद ये फायर इंसिडेंट नहीं हो पाता था और शायद जानें बच जाती थी. तो ये सारे क्वेश्चंस को हम लोगों को भी बड़ा फेस करना पड़ता है. तो जो अकाउंटेबिलिटी या रिस्पॉन्सिबिलिटी फिक्स करना, इस तरीके का अभी जो बहुत बड़े पैमाने पे काम चल रहा है. तो मेरी रिक्वेस्ट यही है कि एग्जिस्टिंग बिल्डिंग हो या आप कोई नया बिल्डिंग प्लान कर रहा हो, you choose an architect who has a thorough knowledge of National Building Code, Fire Act and the UDCPR. बहुत कम लोग हैं. हम लोग तो फ्री कंसल्टेंसी भी प्रोवाइड करते हैं विदाउट चार्जिंग एनीथिंग. आप अपने आर्किटेक्ट के साथ हमारे साथ आते हैं, हमारे पास आते हैं तो हम लोग उसको 15-20 आधा घंटे तक के आपके प्लान पे बात कर सकते हैं, जो एक प्रोफेशनल आपको जिस चीज के लिए चार्ज करेगा. आलोक जी को इसका एक्सपीरियंस है, काफी बार वो नक्शे लेके हमारे पास आए, उनको हम लोगों ने कंस्ट्रेंट बताया कि ये नहीं हो सकता, फिर उन्होंने उसमें चेंजेस किए. मेरे ख्याल से उन्होंने तो साइड भी चेंज की, प्लॉट भी चेंज कर दिया कि देखा कि इट इज नॉट फिजिबल, तो उन्होंने सारा प्लॉट ही वो चेंज कर दिया. तो इस तरीके का गाइडेंस और सपोर्ट हम लोगों की तरफ से हमेशा है, बिकॉज अल्टीमेटली इट इज गोइंग टू रिड्यूस आवर वर्क. तो हमारा काम कम होने वाला है, इसलिए हम लोग बाद में जो कॉम्प्लिकेशन आते हैं उसको पहले ही अगर एड्रेस किया जाए, हम लोगों के कंसल्टेशन में अगर उसको पहले ही क्लियर किया जाए तो एक स्मूथली आपका जो प्रोजेक्ट है वो आगे बढ़ेगा. जो ज्यादा से ज्यादा फायर एक्ट के जो टॉपिक्स है डॉक्टर गहूकर हैज ऑलरेडी कवर्ड. तो अभी जो एक हम लोगों के सामने बड़ा टास्क है, इट इज इवैक्यूएशन ऑफ अ हॉस्पिटल. वो बड़ा एक सीरियस इशू है. जो लाइफ सपोर्ट पे जो पेशेंट होते हैं, अभी जितने भी इंसिडेंट देखे हैं वो सारे ICUs में हुए. वो क्यों हुए, क्या हुए, उसके बारे में बहुत सारे डेलिब्रेशन ऑलरेडी हो चुके हैं. और हम लोगों को अभी ये पता है कि हम लोगों ने बहुत ज्यादा सैनिटाइजर ICU में यूज होता है, फिर वो जाके एक्यूमुलेट होता है, फॉल्स सीलिंग में स्टकअप होता है, ऑक्सीजन रिच एनवायरमेंट भी वहां पर होता है. इसलिए एक आग के लिए बहुत पोषक वातावरण होता है. एक सिंगल छोटा सा स्पार्क भी फायर को इग्नाइट करता है. और पेशेंट बीइंग ऑन अ लाइफ सपोर्ट, दे कैन नॉट बी मूव्ड आउट ऑफ दैट एरिया, और ऐसे भी या तो वैसे भी उनका कैजुअलिटी या फैटिलिटी होना ही है. तो फिर इसको कैसे अवॉइड किया जाए? तो नेशनल बिल्डिंग कोड एंड नेशनल फायर प्रोटेक्शन एसोसिएशन ऑफ अमेरिका, दे हैव ऑलरेडी डन लॉट ऑफ रिसर्च वर्क एंड they have suggested many things in their literatures. तो नेशनल बिल्डिंग कोड में भी इसमें कॉम्प्रिहेंसिव एक आइडिया है, उन्होंने भी उसमें कुछ गाइडलाइंस दिए हुए हैं। अगर वो आप प्लानिंग स्टेज में अगर ध्यान में रखते हैं तो ये सारे इंसिडेंट को हम लोग एटलीस्ट फेस कर सकते हैं। जितना भी जो इंसिडेंट का जो तीव्रता है उसको कम कर सकते हैं, अवॉइड नहीं कर सकते तो कम से कम उसका इंटेंसिटी कम कर सकते हैं, जो होने वाली फैटिलिटी है उसको रिड्यूस कर सकते हैं। तो उन्होंने एक स्टेज वाइज इवैक्यूएशन का कंसेप्ट है, फिर कंपार्टमेंटेशन का एक कंसेप्ट है। तो हॉस्पिटल आप एक ही बड़ा जनरल वार्ड करके जैसा लेते हो अनकंपार्टमेंट, उसके बजाय आप छोटे छोटे वार्ड्स में उसको कन्वर्ट कीजिए। और वो भी जो कन्वर्शन है या वो जो आपका पार्टीशन है, इट शुड नॉट बी ऑफ एनी फ्लेमेबल मटेरियल और एल्यूमिनियम और एनी अदर मटेरियल जिसमें फायर रेजिस्टेंस कैपेसिटी कम हो या जो स्मोक को ट्रैप करने में या हीट को ट्रांसफर करने में मदद करता हो। ऐसे यूज न करते हुए अपने नॉर्मल जो स्टैंडर्ड इंडियन प्रैक्टिस है 9 इंच की ब्रिक वॉल, इट हैज ऑटोमेटिकली फायर रेजिस्टेंस ऑफ 4 आवर्स। तो अगर ऐसा करते हैं तो फायर एंड स्मोक इफेक्ट्स विल नॉट ट्रेवल टू द अदर कंपार्टमेंट। और अगर वो नहीं होता तो यू विल हैव सब्सटेंशियल टाइम कि आप उनको वहां से निकाल के दूसरे कंपार्टमेंट में रख सकते हैं, तो जिसको प्रोग्रेसिव इवैक्यूएशन भी बोलते हैं। एक अफेक्टेड एरिया से निकाल के दूसरे सेफ एरिया में डाल दिया, फायर वहां तक के जब तक के पहुंचेगी उसके बाद आपने दूसरे कंपार्टमेंट में शिफ्ट किया और उसके बाद एक फाइनल इवैक्यूएशन या कंप्लीट इवैक्यूएशन बोलते हैं उस तरीके का फाइनल इवैक्यूएशन। तो वो ये सब करने के लिए दूसरा जरूरी एस्पेक्ट है ट्रेनिंग ऑफ योर स्टाफ। उनका ट्रेनिंग बहुत जरूरी है। आप किसी भी नए स्टाफ को इंक्लूड करते हो, आपके यहाँ रिक्रूट करते हो, तो एक स्टैंडर्ड प्रैक्टिस जो इंडस्ट्री में होती है कि 3 दिन का उसका ओरिएंटेशन का ट्रेनिंग होता है। या आप किसी भी फॉरेन कंट्री में चले जाइए, बुर्ज खलीफा में अगर आपका ऑफिस है और आपको वहाँ पर जॉब लगी है तो पहले तो आपको वहाँ 3 दिन का ओरिएंटेशन ट्रेनिंग मिलेगा। इसमें मेडिकल फैसिलिटीज कहाँ कहाँ है, फायर की रेस्क्यू फैसिलिटीज कहाँ है, रिफ्यूज एरिया कहाँ है, उसको उस बिल्डिंग से एक्वेंटेड करने के बाद ही उसको फिर उसके जॉब के सीट पे बिठाया जाता है। तो इतना अच्छा सेफ्टी कल्चर रहेगा तो ही वो 800 मीटर की बिल्डिंग बना सकते हैं। तो हम लोगों को भी ये सोचना चाहिए कि ये तो करना ही है। अगर हम लोग मल्टी स्टोरीड और 5 स्टार कैटेगरी के हॉस्पिटल्स बना रहे हैं तो हम लोगों को इस लेवल का अपना सेफ्टी स्टैंडर्ड बढ़ाना ही पड़ेगा। और ये जो स्टेज वाइज इवैक्यूएशन हम लोग जब अचीव करना चाहते हैं तो ये स्टाफ के ऊपर ही हम लोगों को 100% डिपेंड करना पड़ेगा, क्योंकि फायर ब्रिगेड को पहुंचने में किसी भी शहर में 20 से 25 मिनट से ज्यादा का ही समय लगने वाला है। हाँ, अगर एकदम इमीडिएट बाजू में ही फायर स्टेशन हो तो बात अलग है, लेकिन जो रिस्पॉन्स टाइम है जो ट्रैफिक की वजह से या बाकी दूसरे कंडीशन की वजह से 25 मिनट के पहले पहुंचना मुश्किल है, और 25 मिनट में वो स्मोक फील्ड एटमॉस्फेयर में और हॉट गैसेस में सरवाइव करना नामुमकिन है। तो अभी किसी ने जैसा बताया था कि डॉक्टर्स एंड द हेल्थ वर्कर्स आर नॉट फायर फाइटर्स, लेकिन अभी का सीन ऐसा है कि उनको बेसिक फायर फाइटर या फायर वॉलंटियर करके काम करना ही पड़ेगा अगर उनको हाई राइज बिल्डिंग या इतने बड़े हॉस्पिटल्स में काम करना है। जो सिस्टम लगे हैं वो उनको ही यूज करना है, वो सिस्टम ऑटोमेटिक इन नेचर होना चाहिए। आज भी सिर्फ फायर के कंप्लायंसेस के लिए एक सर्टिफिकेट बी सर्टिफिकेट देने के लिए सिस्टम इंस्टॉल करते हैं, बट दे आर नॉट इन ऑटोमेटिक मोड। ये बहुत इंपॉर्टेंट एस्पेक्ट है। सिस्टम होने के बाद भी आपने लाखों करोड़ों रुपए उस पर खर्चा कर दिया, लेकिन जब उसकी रिक्वायरमेंट है वो यूजलेस साबित होते हैं, क्योंकि वो दे आर नॉट ऑटोमेटिक इन नेचर, वो ऑटो मोड पे रखते ही नहीं। जैसे ही हाइड्रेंट वॉल ओपन किया तो पानी आ जाना चाहिए, पंप ऑटोमेटिक स्टार्ट होना चाहिए, उसके लिए एक पैनल की सेटिंग होती है और जनरली वो ऑफ पे रखी जाती है। डिटेक्शन सिस्टम का भी वैसा ही है हिंदुस्तान में। अगरबत्ती लगाना ज्यादा जरूरी है इसलिए डिटेक्शन सिस्टम ऑफ कर देते हैं। तो वो जो डिटेक्टर का जितना इन्वेस्टमेंट है, उसका जो पर्पस है या उससे जो अर्ली वार्निंग मिलना चाहिए वो नहीं मिलती। नागपुर म्युनिसिपल कॉर्पोरेशन उससे एडवांस सिस्टम में आया था 5-6 साल पहले। हम लोगों ने एक फायर अलर्ट हॉटलाइन सिस्टम लगाया हुआ है, आपके डिटेक्टर्स हमारे कंट्रोल रूम के साथ जोड़े हुए। तो डॉक्टर लीना भिरे मैडम के इससे एक हम लोगों को सायरन आया था, वार्निंग आई थी, तो हम लोग वहां पर पहुंचे, देखे सब जगह तो कहीं पर भी स्मोक नजर नहीं आ रहा था। तो फिर ये चला कैसे? तो पता चला कि एक रूम में जो डिलीवरी हुई जो पेशेंट थी तो उसकी मदर कुछ अजवाइन भूंज रही थी। तो उससे वो डिटेक्टर एक्टिवेट हुआ और वो हम लोगों को टर्न आउट करना पड़ा। उसी सिस्टम ने एक बार लोकमत बिल्डिंग का भी फायर डिटेक्ट किया था, 7th फ्लोर पे था, स्मोक डिटेक्ट किया, हम लोगों की गाड़ी वहां पहुंच गई और हम लोग जो भी उनके फायर सेफ्टी ऑफिसर थे उनको बता रहे थे कि ये फायर आपके यहाँ हुआ है और हम लोगों को अलार्म आया, आप देख लीजिए, आप अपना जो भी मेजर्स है वो उसमें फाइटिंग शुरू कर दीजिए। दे सेड कि यार हम लोग ऊपर से नीचे तक के पूरा घूम के आए, कहीं पर भी हमें फायर नजर नहीं आया, ये शायद फॉल्स अलार्म। लेकिन अलार्म आया तो जैसा बोलना, आग लगी तो धुआं उठेगा, या धुआं उठा है तो आग कहीं ना कहीं लगी होगी। तो वो प्रिंसिपल पे हम लोगों ने और थोड़ा सा अंदर जाके देखा तो फॉल्स सीलिंग में एक केबल में फायर था और वो अच्छे से जल रहा था। जैसे ओपन किया तो वो फ्लैश ओवर हो गया था। तो हम लोग ऑलरेडी वहां पे अपने होस पाइप के साथ रेडी थे, इसलिए हम लोग इमीडिएट वो फायर को पुट ऑफ कर सके और जो मेजर जो ट्रेजेडी होने वाली थी वो बच गई। तो ये डिटेक्शन सिस्टम का भी अपना एडवांटेज है, तो अर्ली अपने को वार्निंग मिल जाती है और इमीडिएट जो एक बड़ी ट्रेजेडी में तब्दील होने वाला हादसा है वो इमीडिएट एक्शन लेके हम लोग उसको काबू कर सकते हैं। तो ऐसे सिस्टम को अगर बंद करोगे लगाने के बाद, जस्ट फॉर द सेक ऑफ हैविंग कंप्लायंस, अगर उसको इंस्टॉल करते हो, इतना सारा खर्चा करते हो और बाकी फालतू से चीजों के लिए उसको अगर ऑफ रखते हो, भले वाटर बेस्ड होगा या डिटेक्शन सिस्टम होगा, तो ये इसमें सोचने वाली बात है कि जो मैनेजमेंट है जो इस पे इतना खर्चा करता है, तो फायर के सिस्टम हमेशा रेडी टू यूज पोजीशन में होने चाहिए। स्टाफ को उसका ट्रेनिंग होना ही होना चाहिए। आपका स्टाफ छोड़ के जाता है, नया रिक्रूट होता है, उसको उसका ट्रेनिंग देना जरूरी है। आप एनुअल मेंटेनेंस कॉन्ट्रैक्ट वो फायर सिस्टम जो लाइसेंस एजेंसी है उसके साथ करना चाहिए। बी सर्टिफिकेट के वक्त उसको बोला जाता है कि बी सर्टिफिकेट दो। अगर हम लोग उसका अगर मेंटेनेंस का वर्क ऑर्डर मांगे तो आप शायद प्रोड्यूस ना कर सको। आगे में ऐसी कुछ लीगल कॉम्प्लिकेशंस आती है जिसमें आपको ये प्रूव करना है कि माय सिस्टम वाज अंडर मेंटेनेंस विद दिस एजेंसी। क्योंकि जो बी सर्टिफिकेट है वो प्रोस्पेक्टिव नहीं है, वो रेट्रोस्पेक्टिव है कि दिस सिस्टम वाज अंडर माय मेंटेनेंस। वो बी सर्टिफिकेट इस तरीके का सर्टिफिकेट, तो आगे वो सिस्टम की गारंटी नहीं रह रहा कि सिस्टम विल बी इन वर्किंग कंडीशन, लेकिन पास्ट ये सिस्टम अंडर मेंटेनेंस है और मैं इसकी जिम्मेदारी ले रहा हूँ करके वो बी सर्टिफिकेट है। तो आपने अगर आज सारा आईटी बेस्ड है, आप फोटो भी निकालते हो तो लोकेशन और टाइमिंग आ जाता है, तो आप कैसे डॉक्यूमेंट प्रोड्यूस करोगे कि दिस सिस्टम इज अंडर मेंटेनेंस एंड द वर्क ऑर्डर वाज गिवन प्रायर टू 6 मंथ। तो ये बहुत मुश्किल चीज है, क्योंकि मैं कुछ इंक्वायरीज के टीम का पार्ट रहा हूँ, तो ये सारे मुद्दे वहां सामने आए थे। तो मेरा एक सिंसियर रिक्वेस्ट है कि आप लोग जो बी सर्टिफिकेट देते हो तो साल का एनुअल मेंटेनेंस एग्रीमेंट कॉन्ट्रैक्ट उसको दीजिए, ये बहुत इंपॉर्टेंट डॉक्यूमेंट है। अगर उसके बाद भी कुछ होता है तो उसको एक एक्सीडेंट करके ट्रीट किया जाएगा, लेकिन अगर नहीं है तो वो निग्लिजेंस और फिर वो जो है अप्रत्यक्ष त्या गुन्ह्यामध्ये सामील होने वगैरह वो सारे क्लॉज अट्रैक्ट हो जाते हैं। तो हम लोग, इंटेंशन आपका भी अच्छा है, आप सिस्टम लगा भी रहे हैं, कर भी रहे, जो भी कंस्टेंट है, अगर समझ लो वाटर टैंक वहां नहीं बन सकती, उसमें हम लोग कुछ रिलैक्सेशन दे रहे हैं। पुराने बिल्डिंग्स जो हॉस्पिटल करके सैंक्शन या ऑफिस करके सैंक्शन है और हम लोग फिर भी बी सर्टिफिकेट को आपको उसमें रजिस्ट्रेशन परमिट कर रहे हैं, तो हम हमारी तरफ से तो लीनियंट है, लेकिन जबकि वो स्ट्रक्चरल चीजें आज भी न सैंक्शन है ना वो हॉस्पिटल के लिए डिजाइंड है। स्टेयरकेस की विड्थ भी 2 मीटर नहीं है। बहुत से जैसे हॉस्पिटल है, नीति गौरव लीजिए, या उस जमाने के जो भी रामदासपेट और धंतुली के हॉस्पिटल, तो तभी का डीसीआर फायर एस्केप मिनिमम 0.75 मीटर पे अलाउ करता था, तो वो मिनिमम था, तो लोगों ने मिनिमम ही बनाया। तो वहां से बताइए 0.75 से कहाँ से स्ट्रेचर से हम लोग नीचे उतारेंगे पेशेंट को। तो कुछ चीजें हॉस्पिटल की जो उसकी पर्टिकुलर रिक्वायरमेंट है वो उस कंप्लाई होनी ही चाहिए। वहां पर अगर ये सब चीजें करने के बाद अगर यूज में नहीं आती है तो आपका स्टाफ भी कुछ नहीं कर सकेंगे, हम भी कुछ नहीं कर सकेंगे और वो सिचुएशन हेल्पलेस रहेगी। अभी जो नया एडिशन हुआ है फायर एक्ट में, जो अमेंडमेंट हुआ है, तो बहुत प्रेशर था पूरे थ्रू आउट इंडिया की हॉस्पिटल और जो हेल्थ केयर फैसिलिटीज जो है वो बहुत अपने देश में कम थी, वो बढ़ाना बहुत ज़रूरी था। और जैसे कुछ मेट्रोज है, कुछ सिटीज़ ऐसे हैं जहाँ वो वर्टिकल ही जा सकते थे, तो बहुत फायर डिपार्टमेंट ने अपोज करने के बाद भी फिर उसको 45 मीटर तक के दिया है, लेकिन 45 मीटर परमिट किया है सब्जेक्ट टू कंप्लायंस ऑफ द नेशनल फायर प्रोटेक्शन एसोसिएशन नॉर्म्स। अब नेशनल फायर प्रोटेक्शन एसोसिएशन ऑफ अमेरिका, तो अमेरिका के लेवल के अगर सेफ्टी मेजर्स अगर लेते हैं तो आपको 45 मीटर तक का हॉस्पिटल डिजाइन आप कर सकते हैं। जो 30 मीटर के ऊपर है वहां पर आप जहाँ सीरियस एंड ज्यादा एम्बुलेटेड पेशेंट हो उनको वहां नहीं रख सकते। नर्सिंग स्टेशन, डॉक्टर रेसिडेंस या तो अकाउंट्स डिपार्टमेंट, इस तरीके के डिपार्टमेंट आप वहां रख सकते हैं, लेकिन बाकी जो पेशेंट को अकोमोडेट करना है वो 30 मीटर से नीचे ही करना है। तो और बाकी जो फायर फाइटिंग मेजर्स है वो इन्होंने तो कवर कर लिया है डॉक्टर गौकर ने। तो रेस्ट जो नागपुर का सीन है, तो वी आर ऑलरेडी वर्किंग विथ यू। आपके बहुत से 8-8, 10-10 लोग हमारे पास आते हैं और हम लोग फ्री ऑफ कॉस्ट उनको ट्रेनिंग दे रहे हैं, फायर फाइटिंग का भी ट्रेनिंग दे रहे हैं, ओरिएंटेशन करा रहे हैं। हमारे पास ट्रेनिंग के वीडियोस है, कुछ वीडियो सर्कुलेट आपके साथ भी किए थे ताकि स्टाफ को भी पता चले कि ये बहुत इंपॉर्टेंट इशू है। उनको खुद की तो जान बचानी है लेकिन साथ साथ पेशेंट की भी बचानी है, और वो तभी कर सकते हैं अगर वो ट्रेंड है। सिस्टम अपनी जगह लगे हुए हैं, लेकिन अगर उसका यूज कैसा करना और उसके ऊपर अगर कॉन्फिडेंस ना हो तो वो सिस्टम काम नहीं कर सकते। वेलट्रीट हॉस्पिटल के इंसिडेंट बहुत ही छोटा सा फायर था, जो एसी से फायर शुरू हुई थी और कर्टन जला था। और कर्टन जब जलता है तो फ्लेम ज्यादा आती है क्योंकि वो थोड़ा सा उसका जो एक्सपोजर है वो जो थोड़ा ज्यादा होता है। फिर भी वो जो स्टाफ था तो तीनों ने भी फायर एक्सटिंग्विशर यूज किए, बहुत अच्छे तरीके से यूज किए, फायर को कन्फाइंड भी किया, फायर को बढ़ने भी नहीं दिया। लेकिन स्मोक इतना हो चुका था क्योंकि आईसीयू था, पूरा पैक था एयर कंडीशन रूम होने के कारण, तो वो स्मोक फील्ड एटमॉस्फेयर में बाकी पेशेंट गए, बर्न इंजरीज से नहीं गए थे। तो एक छोटा सा भी अगर कर्टन भी जलता है तो इतना बड़ा इंसिडेंट हो सकता है। ऐसा ही भंडारा में भी सेम हुआ। वो जो बच्चों का क्रेडल था जिसमें वो रखा हुआ था सिर्फ वो जला था, और वो फोम जो होता है हाइड्रोकार्बन होता है, उसका जो जलने के बाद जो भी उसके जो स्मोक निकलता है वो टॉक्सिक रहता है। और सिर्फ उतने ही गद्दी ने बाकी 9 बच्चों को भी खत्म कर दिया था। वहाँ कोई बड़ा फायर नहीं था, कोई फ्लेम्स नहीं थी, वहाँ कुछ ज्यादा जला भी नहीं था। सिर्फ जो प्राइमरी जो व्हाट वी कुड अंडरस्टैंड जो साइट विजिट करने के बाद जो थर्मोस्टेट था जो ऑटोमेटिकली ऑफ और ऑन होता है पर्टिकुलर टेम्परेचर पे, वो फंक्शन नहीं हुआ। और वो जो बॉडी टेम्परेचर मेंटेन होता है 34-35 के आसपास, तो वो जो हीटिंग डिवाइस था वो एक्सीड कर गया था और 80 डिग्री पर उसने वो गद्दे को जला दिया था। तो छोटी सी ही बहुत ही माइनर चीज थी, इमीडिएट अगर वहां कोई अटेंड करने वाला होता तो शायद बच सकता था, ऐसा जो इन्वेस्टिगेटिंग एजेंसी है उनका व्यू बनता है। और फिर वहां जिसको होना था वो नहीं था, और फिर बाद में ये बाकी लीगैलिटी शुरू होती है और उसमें कल्प्रिट किसी न किसी एक को कर दिया जाता है। तो जो स्कैपगोट के क्राइटेरिया में हम लोग तो बहुत पहले आते हैं ऐसे जगह पे कि आपने वहां का ऑडिट किया था क्या, फिर फॉलोअप लिया था क्या, फिर फर्दर एक्शन क्यों नहीं लिया। तो ये सारे, अब फॉर्चुनेटली ऐसा है कि फॉर्चुनेटली नहीं बोलना चाहिए, अनफॉर्चुनेटली नागपुर में जो गवर्नमेंट हॉस्पिटल है उसके ऑडिट्स तो हम लोग आमरी इंसिडेंट की तरफ से करते हुए आए हैं, तो डॉक्यूमेंट वाइज हम लोग फुल प्रूफ है। बात सिर्फ यही है कि जो पीडब्ल्यूडी जैसा आपने बताया कि हॉस्पिटल्स जो भी डीन होते हैं वो एडमिनिस्ट्रेटिव पोस्ट है, इसलिए उनकी भी रिस्पॉन्सिबिलिटी बनती है। तो वो आगे से ज्यादा पीडब्ल्यूडी को फॉरवर्ड कर सकते कि दिस सिस्टम इज रिक्वायर्ड, वी आर इन रिसिप्ट ऑफ सच नोटिस फ्रॉम फायर डिपार्टमेंट। वो वहां फॉरवर्ड करते, पीडब्ल्यूडी अपना डिजाइन बनाता है और उसके लिए जो कॉस्टिंग है वो एस्टिमेट निकाल के वो बजट में मांगता है। अगर बजट ही उसको अगर प्रोवाइड नहीं किया जा सकता तो वो सिस्टम वहां लगने से रहा। तो ऐसे नागपुर म्युनिसिपल कॉर्पोरेशन ने गवर्नमेंट हॉस्पिटल में फायर सेफ्टी सिस्टम लगने चाहिए इसलिए खुद होके स्टेट गवर्नमेंट को लिखा, जबकि हमारी कोई जिम्मेदारी नहीं है उसमें। लेकिन फिर भी जब अश्विन मुदगल सर कमिश्नर थे तो यहाँ से सचिव को लिखा था पीडब्ल्यूडी के कि फायर सेफ्टी सिस्टम्स रहना बहुत जरूरी है, एंड वी हैव अंडरस्टूड कि जस्ट ड्यू टू लैक ऑफ फंड्स द फायर सिस्टम आर नॉट एग्जीक्यूटेड इन आवर गवर्नमेंट हॉस्पिटल। तो हम लोगों ने वो भी पत्र गवर्नमेंट को लिखा था। तो ये सारे हमारे सपोर्ट में हैं। तो जो हमारा पार्ट है हम लोग प्ले कर रहे हैं, लेकिन जैसा अभी बताया कि सिस्टम का रहना, फायर एग्जिट का खुला रहना, फायर एग्जिट का रहना, लोकेशन जो स्टेयरकेस के है सिर्फ 2 चाहिए, इसलिए आसपास में 2 दिया, ऐसा ना करते हुए 2 डायगोनली अपोजिट या ऑन द एक्सटर्नल वॉल पे रहना, ये बहुत इंपॉर्टेंट फैक्टर है। स्टेयरकेस का बाकी प्रीमाइसेस से कट ऑफ रहना, जो फायर लॉबी जिसको कहते हैं, इवन इफ यू हैव टू अचीव एन इवैक्यूएशन थ्रू लिफ्ट, तो वो लिफ्ट लॉबी भी फायर प्रोटेक्टेड लॉबी होनी चाहिए, उसमें भी स्मोक और हीट के इफेक्ट नहीं आना चाहिए, इसलिए उसको भी डबल फायर डोर से, डबल कंपार्टमेंटेशन से उसको कट ऑफ करना चाहिए। और वो लिफ्ट लॉबी के सामने का जो एरिया है वो भी इतना प्रशस्त होना चाहिए कि एट अ टाइम 10 से 20 आपके जो बेड्स है या स्ट्रेचर्स है वहां पे होल्ड पे रखे जा सके। सेम वे रेफ्यूज एरिया, अभी एक नागपुर में एग्जिस्टिंग हॉस्पिटल में एक कॉम्प्लिकेशन चल रहा है, उन्होंने रेफ्यूज एरिया की जगह रूम बना दिए। अब रेफ्यूज एरिया बाय डेफिनेशन इज अ कैंटिलीवर प्रोजेक्शन एंड इट्स लाइक अ बालकनी, तो वहां उसमें भी नहीं हो पा रहा, और उन्होंने ऑलरेडी वहां आईसीयू करके कन्वर्ट कर दिया था। तो अभी हम लोग ये सोच रहे हैं कि रेफ्यूज एरिया में हॉस्पिटल का अगर है तो वहां पर अगर लाइफ सपोर्ट वाला सिस्टम रहता है तो ये तो और एडेड एडवांटेज है। तो उसको बालकनी के तौर पे न देखते हुए एक एडिशनल आईसीयू, जिसको रेफ्यूज आईसीयू करके यूज किया जा सकता है, इस तरीके का अप्रूवल देके उसको हम लोग अभी क्लियर कर रहे हैं। तो जो एग्जिस्टिंग हॉस्पिटल में उसमें जो जो वे आउट मिलते हैं हम लोग कर रहे हैं। नागपुर में प्रॉब्लम ऐसा है कि नीचे दुकान है, रेस्टोरेंट्स है, फिर ऊपर कुछ पार्ट में एक दूसरे ऑर्गेनाइजेशन का हॉस्पिटल है, फिर तीसरे का हॉस्पिटल है। और नागपुर में क्योंकि सोसाइटी कल्चर कभी आया ही नहीं, तो कोई भी एक सारे मिलके मेंटेनेंस निकालना और बिल्डिंग को मेंटेन करना इस तरीके का कल्चर नहीं है, इसलिए ये सारे प्रॉब्लम्स है। और फायर का सिस्टम आइसोलेशन में नहीं हो सकता, ये एक एक पार्ट में नहीं हो सकता। जो फायर के मेजर्स लगते हैं बाय नेशनल बिल्डिंग कोड और या अपना यूडीसीपीआर हो, तो वो एज अ सिंगल यूनिट एज अ सिंगल बिल्डिंग ही ट्रीट होती है। उसकी वाटर रिक्वायरमेंट जो है वो अलग के लिए अलग अलग टैंक बनाने की जरूरत नहीं होती है, उसको एक सिंगल टैंक में ही पूरे बिल्डिंग को प्रोटेक्शन देना है विद सिंगल पंप हाउस। सब अलग अलग करने गए तो उस कॉस्ट को बढ़ाएंगे, और जो उसमें अचीव करना है ये 100% स्प्रिंकलर सिस्टम या फुल्ली कवर्ड स्प्रिंकल्ड बिल्डिंग, तो वो सब अचीव नहीं होगा। तो ये उसमें भी हम लोगों ने सारे जो बिल्डिंग्स के रेंटेड वाले या ओनर्स थे, जितने भी ओनर्स थे, उनको हम लोगों ने एक छत के नीचे लाके उनको यूनाइट करके उनका एसोसिएशन भी फॉर्म करा के दिया, क्योंकि हम लोगों को आगे बताना पड़ता है कि ये इतने हॉस्पिटल्स नागपुर में सेफ हो चुके हैं। क्योंकि हर अधिवेशन में एलएक्यू आता है की नागपुरातले रुग्णालय असुरक्षित, आप पेपर में देखते होंगे, एवढे असुरक्षित, एवढे सुरक्षित। वो आंकड़े भी कहाँ से आते पता नहीं, लेकिन हो सकता है उनकी कोई खुफिया टीम काम कर रही हो और सारे इंस्पेक्शन करते हो। तो हम लोगों को तो पहले ही सीधा लिखना पड़ता है कि जो फिगर्स आर नॉट मैचिंग विथ अस, तो हम सीधा बोलते हैं कि हे खरे नहीं। बाद में फिर वस्तुस्थिति बतानी पड़ती है, क्योंकि जो अधिवेशन में जो मिनिस्टर उसको जवाब देने वाला है तो उसके पास सारा डिटेल होना चाहिए। तो वो उसमें फिर हम लोग ये सारे फिगर्स तो बोलते यार, लास्ट टाइम जवाब दिया था तभी 360 हॉस्पिटल थे, और ये नेक्स्ट अधिवेशन तक के भी 360 ही हॉस्पिटल है, आप कुछ आगे करते हो कि नहीं करते हो? तो हम लोगों की भी वही रिक्वेस्ट रहती है, यार करो, 360 से आंकड़े आगे भी लेके जाना है, क्योंकि नेक्स्ट एलएक्यू में भी क्वेश्चन आने ही वाला है। और अभी तो ये ट्रेंड हो चुका है और इंसिडेंट भी ऐसे हो रहे हैं कि वो हम लोगों को भी चैन से बैठने नहीं दे रहे। अगर हरियाणा में भी इंसिडेंट होता है तो अपने नागपुर में उसका इफेक्ट सीधा सीधा दिखाई देता है। तो ये था फायर डिपार्टमेंट का व्यू ऑन फायर सेफ्टी मेजर्स इन हॉस्पिटल बिल्डिंग, और जो आज का सीन है और जो समस्या है उसके बारे में। इसके बाद अगर किसको और इससे ज्यादा कुछ दूसरे कुछ पूछना हो तो प्लीज.
We thank you, Uchke sir, for an extensive deliberation on this fire safety norms. And from IMA, we would like to know a lot of things from you, and how can we manage things in our hospitals, we being totally in a different field. So I would like to have questions, a lot of questions should be there from our senior doctors and friends to know about fire safety norms. The one question I have is, as you said, it's the curtains which are causing problems in ICU. So should we ban curtains? What should be done? What should be our take?
Now in market there are fire resistance clothing available. So fire resistance material clothes and hosiery should be used. Even carpeting and low combustible load should be there in a hospital building. आप जो interiors पे ज्यादा खर्चा करते हो, प्लाई का यूज कम से कम करना चाहिए. ग्रेनाइट, स्टोन, जितने भी मार्बल्स है उसका मैक्सिमम यूज कीजिए. आप फायर लोड अगर बढ़ाओगे तो जैसे आपने देखा जो किंग्सवे हॉस्पिटल व्हेन इट वाज अंडर कंस्ट्रक्शन देयर वाज अ ह्यूज फायर, और जो अमाउंट ऑफ स्मोक जो निकल रहा था वो आज के सिचुएशन में अगर होता है तो कम से कम 100 से 150 कैजुअलिटीज वहाँ 100% होगी, क्योंकि उन्होंने सारा ग्लास फसाड से पैक किया हुआ. तभी अंडर कंस्ट्रक्शन था तो स्मोक को वेंट आउट होने में मतलब वेंट आउट हो सका. और उस दिन वहां पर कम से कम 200 से 250 लेबर वो बिल्डिंग में काम कर रहे थे, और वो खुद होके अपना बचाव कर पाए. सारे नीचे सुरक्षित इसलिए आए क्योंकि वहां 5 स्टेयरकेस थी और पांचों के पांचों एक्सटर्नल स्टेयरकेस थी. तो एक्सटर्नल स्टेयरकेस का उसका लोकेशन ये बहुत इंपॉर्टेंट रखता है. वो कोर में होगी तो सारा स्मोक जो है वो फायर फाइट अपने स्टेयरकेस के शाफ्ट में जाता है और वो एग्जिट वे ही ब्लॉक कर देता है. तो नॉन कंबस्टिबल मटेरियल का यूज, फायर रेटेड मटेरियल का ज़्यादा यूज, और जितना नेचुरली वेंटिलेटेड लॉबीज और स्टेयरकेस रख सकते हैं ताकि स्मोक एक्यूमुलेट ना हो, हॉट गैसेस अंदर ट्रैप ना हो. तो इस तरीके का अगर डिज़ाइन रखते हैं सिंपल, आज अपने जितने भी गवर्नमेंट हॉस्पिटल है उसमें भी इतने सालों से कभी इंसिडेंट हुए भी नहीं, या हुए हैं तो उसका इफेक्ट ऐसा नहीं हुआ कि जिसमें कोई कैजुअलिटी हुई है, क्योंकि सारे नॉन आरसीसी ब्रिकवर्क का कंस्ट्रक्शन है, मिनिमम कंबस्टिबल मटेरियल है. और जो किंग्सवे में जो आपने देखा इतना हैवी स्मोक, थिक स्मोक था, जला क्या था? सिर्फ ये 300 चेयर्स जली थी, बाकी कुछ जला नहीं थी. उसका पेस्टिंग का काम चल रहा था, नीचे कारपेट, वेल्डिंग का भी काम चल रहा था और पेंटिंग का, वार्निशिंग का भी काम चल रहा था. तो वो कहीं से स्पार्क वो मिल गया और पूरे 300 चेयर्स वहां जल चुकी थी.
Sir, one important issue, we are always talking about fire safety as if that there will be a fire, and we are designing as per the norms which has been provided by Government of India or your department. I am of the opinion that majority of the time we blame for short circuit. I don't know why this word has been coined and who is the person responsible for identifying this particular specific cause. I am of the opinion that you go to ICCU, many of the devices, medical devices, which are being not calibrated properly, not being safety norms followed by us. We need to implement, we need to execute, we need to design such type of instrument and equipment which are available on portal, Government of India. And that has to be procured and installed in our institutions or hospitals. Rather than designing, or this is also equally important. I mean to say that this is priority, this is important. Second important issue is that why government is not putting their team and identifying those institutions before getting these fires. They must have such type of a department when it is a requirement. A lot of hospitals are there, private, government hospitals. They must have their own team and to see to it that the norms are being followed or not. What are the lapses, and accordingly they should rectify so that further mishaps can very easily prevented. And it should be having a time bond program, I think so.
So actually fire audit or term like fire audit never existed in any rules or any norms till 2019. और अभी भी जो फायर ऑडिट, ये इलेक्ट्रिकल ऑडिट तो इलेक्ट्रिकल ऑडिट का भी अभी जो नॉर्म्स आए हैं, तो दोज बिल्डिंग आर हैविंग सप्लाई ऑफ मोर देन 11 kV नीड टू बी इलेक्ट्रिकल ऑडिटेड. ये तो भी फायर हो रहे हैं, इसीलिए इलेक्ट्रिकल ऑडिट ये शब्द प्रचलन में आया है. तो देर इन नॉर्म्स देर इज नथिंग लाइक इलेक्ट्रिकल ऑडिट, और उसका शेड्यूल और वो कौन करेगा ऐसा कहीं पर भी नहीं है. अभी गवर्नमेंट की तरफ से अगर उसका कुछ कायदे में आता है कि 6 मंथली होना चाहिए, और उसकी जो चेकलिस्ट है या उसकी अथॉरिटी कौन रहेगी, तो वो अगर आता है तो वो फायर डिपार्टमेंट का 80% काम कम हो जाएगा. Now there are many sophisticated devices which can predict fault in any electrical gadgets, और वो IT based solutions है. उसका भी अभी लास्ट टाइम एक सेमिनार लिया था, और गवर्नमेंट हैज ऑलरेडी इशूड गाइडलाइंस रिगार्डिंग दिस डिवाइस, और वो बहुत अच्छा, अगर उसमें और भी आगे में अगर डेवलपमेंट होता है, तो जैसा अपना MCP LCP होता है कि जो पहले से ट्रिप होता है, तो वो भी वो डिटेक्ट करता है और आपको एक SMS आपकी जो मशीन हो रहा है, और वो आगे में फायर का कॉज बन सकता है. तो वो आपको प्रिवेंटिव मेजर्स करके ये जो डिवाइसेस है ये लगना जरूरी है. अगर ये लगते हैं तो फायर फाइटिंग की शायद जरूरत ही ना पड़े.
I think the big hospital must have electrical audit every year. That will give a lot of safety that we do regularly. Second thing, whenever you have got a lot of instruments with you, like AC and ventilators and everything, if you have got a proper person, electrical engineer or a person who is taking care of that instruments, he can definitely give you idea about which instruments are calibrated properly or they are working properly, and they can create any nuisance in the hospital. But these all things, fire safety, electrical safety, everything, it is going to a heavy cost to the hospitals. And that's why most of the people are not giving that much importance, because the cost involved in the establishment is too much, and ultimately it reflects in the patient's bill.
Thank you, sir. We have delegates, more than 200 delegates attending this webinar, and there are some questions from them. Is there any provision of subsidy from government for installation of fire prevention measures in private hospitals?
No, according to my knowledge, there is no such provisions from government side to grant any subsidy for procurement of firefighting systems.
As this is for public safety, so can we have some subsidy, or in future?
Better this you ask this question to the government, because I am officer from Nagpur Municipal Corporation and my jurisdiction is limited to the firefighting and fire service to this city only.
Thank you, sir. Thank you so much.
Thank you, Utske sir, for enlightening us with your knowledge. I would like to ask our chairpersons, Dr. Arbet sir and Dr. Umre sir, to felicitate Utske sir with a memento.
Devtare sir, तुम्ही join करा.
Now, I would like to ask our chairpersons to felicitate our first speaker, Dr. Shailesh Gahukar.
I request Dr. Sanjay Devtare and Sachin join करा.
I request our president, Dr. Devtare sir and Dr. Sachin Gathe sir to join. Now I would like to ask Dr. Devtale to felicitate Dr. Arbet sir. I would like to ask our President, Dr. Devtale sir, and Dr. Sachin Gate sir to felicitate Dr. Alok Umre sir. Thank you. Now the fire workshop will be held here. Demonstration for the fire workshop, disaster management.
I request fire team from fire office to demonstrate the fire evacuation techniques for our delegates.
अभी आपके सामने फायर एक्ट्स, फायर प्रिवेंशन, प्रोटेक्शन सारी चीज़ें होगी। मैं जनरली जब इंसिडेंट होता है ऐसे समय में इवैक्यूएशन किस तरह किया जाता, कैजुअलिटी कैसे हैंडलिंग किया जाती, ये हम लोग अभी डेमोन्स्ट्रेशन देंगे। तो सबसे पहले अगर कोई कैजुअलिटी अनकॉन्शियस है और वहाँ पे आपके सामने दिख रही, तो उसको हम लोग जो ओरिजिनल हमारा फायर फाइटर होता वो फायरमैन लिफ्ट किस तरह लेके जाएगा, उसका डेमोन्स्ट्रेशन आपके सामने यहाँ पे दिखा जाएगा। फायरमैन लिफ्ट एक हाथ लॉक करेंगे और एक हाथ अपने कमर पे ऊपर रखेंगे, वॉकिंग कर सकते हैं। और ऐसे समय पे अगर हमको लैडर से उसको नीचे लाना है तो दोनों हाथ हमारे लैडर के राउंड पे रहेंगे और बैलेंस पे उसको नीचे लाएंगे। तो दोनों हाथ ऊपर करो, लेके आ जाओ। हाँ यस, अभी ये प्रॉपर तरीके से कि कैजुअलिटी यहाँ पे नीचे रहेंगे, उसको प्रॉपर तरीके से उठाना है। नहीं ऐसे चलेगा, कुछ नहीं हो रहा। यहाँ पे कैजुअलिटी को हम लोग प्रिपेयर करेंगे। जो भी चीजें वो पहने हैं, शू है, हेलमेट है, उसको निकालेंगे। जो भी चीजें चुभने वाली हो, बेल्ट हो, जेब में कोई ऐसी पेन्स हो, उसको निकाल लेंगे। अच्छा, ठीक जाएगा। चलो आप सो जाओ। अभी यहाँ पे इस तरह की कैजुअलिटी, स्मोक हो गया था, स्टेयरकेस से आ रहे थे, वहां पे ट्रैप होके गिरे, आपके सामने दिख रहे। जब हमारा फायर फाइटर वहां पे वॉकिंग कर रहा है, उसको दिख रहा है कि इस तरह से कैजुअलिटी, तब सबसे पहले देखेंगे जगह कहाँ पर है, वहां पर लेके आ जाएंगे और प्रिपेयर करेंगे उसको। तो देखेंगे कि उसको कहाँ की जगह से उसको उठा सकते, लिफ्ट कर सकते। ओके, नोकीली चीज जो भी होंगी वो निकालेंगे, फिर प्रॉपर उसको तैयार करेंगे उठाने के लिए। जिस तरह जगह होंगी उस तरह उसका पैर रखेंगे, लेफ्ट साइड है, राइट साइड है, और चीन के पास एक हाथ पकड़ के, पैंट के सिलाई के साथ एक हाथ रहेगा, और उसको टर्न करेंगे। टर्न करके दोनों हाथ उसके बगल में डालेंगे, और जो रेस्क्यूअर है वो आगे बढ़ेगा, कैजुअलिटी वैसी रहेगी। धीरे धीरे उठा के अपने शोल्डर लेवल पे लाएंगे, एक हाथ से उसका हैंड कैच करेंगे, और एक पैर उसके दोनों पैर के बीच में डालेंगे, अपनी बॉडी टोटली झुका देंगे और उसको लिफ्ट करेंगे। इस तरह वो फायरमैन लिफ्ट की जाती। मैडम ओके, चलिए। सेकंड, चलते चलते स्टेयर कैसे पैर, उसके पैर में मोच आई तो उसको सहारा देके कैसे लेके चलते, वन मैन वुमेन क्रैच। रेस्क्यूअर अपना पाँव, जो कैजुअलिटी होंगे उसको अपने पैर पे रखेंगे, कमर के सपोर्ट के साथ उसको लेकर आएंगे। आपको चलने में दिक्कत है, प्रॉपर उठा के लेके आना है। अभी दोनों पाँव में मोच आई तो दोनों पाँव का सपोर्ट कैसे देंगे? हाँ ठीक है, दोनों पैर रखेंगे, जैसा हम लोग वॉकिंग करते हैं भाई इस तरह ही वॉकिंग करके उसको लेके जाना है। इसके बाद ये वॉकेबल थे, अभी ये चल ही नहीं सकते, बैठे हैं, इसको अपने हाथ से उठा के लेके जाना। 2 हैंडेड सीट, सीट कैसी बनाते वो दिखा देंगे, ऊपर दिखा दो सबको। इस तरह मुट्ठी होना चाहिए, अगर प्रॉपर उसको इस तरह रखेंगे तो स्लिप हो सकती है, तो इस तरह मुट्ठी रखेंगे। ये थोड़ा पुश भी करेंगे तो एक दूसरे के तरफ खींचे आएंगे, ना कि उसकी मुट्ठी खुल जाएगी। इस तरह उठा के उनको सेफ जोन में अभी चलते चलते उसके पाँव में कई फ्रैक्चर्स हो गया, वो चल नहीं सकते, तो 3 हैंडेड सीट से कैसे लेके आएंगे वो बता देंगे। वो पैर फ्रैक्चर है उसका, है ना। चलिए वॉक करके यहां तक लाके छोड़ेंगे जल्दी। अभी यहाँ पे ऐसे है कि कुछ कैजुअलिटी हम लोग वीक नहीं मिलेंगे, कोई हेवी कैजुअलिटी मिल सकती है, तो हमारे दुबे साहब को हमारे रेस्क्यूअर यहाँ से लेके जाएंगे। आइए, 4 हैंडेड सीट। हाँ सर, ऐसे चलते जाइए। बढ़ जाइए, अब बढ़ जाइए, कुछ नहीं होगा, बढ़ जाइए, लेके जाएंगे आपको 2 किलोमीटर। हम लोग वीक को भी लेके जाते, मगर हमारे पास हमारे वजन से भी अगर अबा हो तो उसको भी शिफ्ट करते, हम लोग वहां पे नहीं छोड़ेंगे। इसके बाद एस मेथड। एस मेथड ऐसा है, हमारे पास मैन पावर कम है, ज्यादा कैजुअलिटी है, जल्दी से जल्दी शिफ्ट करना है, तो एस मेथड करेंगे। एक हाथ उसका गर्दन के तरफ रहेगा, 2 हाथ कमर के पास रहेंगे, एक हाथ उसके पैर के तरफ रहेंगे। कैजुअलिटी को जल्दी सुलाना है और पट से अप करना है दोनों हाथ। चलिए आगे चलते हुए ऐसा लेके आएंगे। इसके बाद 4.5 मेथड्स, एक सामने की तरफ जाएंगे, एक पीछे की तरफ जाएंगे, दोनों एक रेस्क्यूअर अपने कंधे में हाथ रखेंगे, वहां तक चलना है और जल्दी से बेड पे होंगे, कहीं भी बैठे होंगे तो जल्दी से इस तरह लेके चलेंगे। इसके बाद किसी को पेट में मार है तो उसको पीके बैग या उसके चेस्ट में मार है तो कैसे लेके जाएंगे ये बता देंगे। पीके बैग, इस तरह उसको सिक्योर करेंगे और वहां से शिफ्ट करेंगे। थोड़ा कैमरे के तरफ से चलना। पीके बैग्स रिवर्स, लॉक करो। अभी एक चेयर, थोड़ी सी प्लास्टिक चेयर है चेयर कैरी, जैसा अभी कई कई हॉस्पिटल में व्हील चेयर होती है, पर हम लोग व्हील चेयर का यूज नहीं करते। जो हमारे पास अवेलेबल है, इम्प्रोवाइज जो भी चीजें मिलती है उसका यूज करके हम लोग शिफ्ट करेंगे। तो पहले जो भी पेशेंट्स होंगे या जो कैजुअलिटी होंगे उसको चेयर में बिठाएंगे। चेयर को अपने तरफ रेस्क्यूअर अपने तरफ थाई पे लेगा, एक रेस्क्यूअर सामने की ओर जाएंगे, चेयर के दोनों पाँव पकड़ेंगे और इजीली उठा लेंगे। ऐसे जो पेशेंट रहते जैसा बहुत ही ओल्ड एज लेडीज हो या प्रेग्नेंट लेडी है, इस तरह के लेडीज को हम लोग शिफ्ट करते हैं ताकि उसको और उसके बच्चों को भी तकलीफ ना हो। इसके बाद बहुत ज्यादा कैजुअलिटी हमारे पास स्ट्रेचर कम पड़ रहे हैं, तो ऐसे में हम लोग क्लॉट लिफ्ट, जो अपने कपड़े पहने हैं उसी कपड़े से हम उनको उठाएंगे। क्लॉट लिफ्ट, क्रॉस में पकड़ना है, उन्हीं के कपड़े पकड़ना है। उधर जब मैं यहां से लिप बोलूंगा तब उठाना है। हो गया? रेडी है? लिप कैजुअलिटी, हम लोगों को कोई स्ट्रेचर की जरूरत नहीं, कोई ब्लैंकेट की जरूरत नहीं है, उन्हीं के कपड़े द्वारा हम लोग शिफ्ट करेंगे। अभी हमारे पास ब्लैंकेट है, कर्टेन्स है या टेबल क्लॉथ है, उसका भी यूज करके हम लोग कैजुअलिटी को शिफ्ट करेंगे। ये जो ब्लैंकेट है या क्लॉथ लिप है, इनर साइड उसको रोल करेंगे, गर्दन की तरफ ज्यादा रोल करेंगे ताकि गर्दन उसको सिक्योर हो जाए। क्रॉस में पकड़ेंगे, दोनों हाथ क्रॉस में। जब लिप बोलेंगे तब उठाना है और इजीली लेके जाना है। अब ये इवेकेशन स्ट्रेचर ज्यादा अगर हमारे पास कैजुअलिटी है तो हम लोग उसके स्ट्रेचर की राह न देखते हुए ऐसे ही क्लॉथ अगर मिलते हैं हमारे पास तो उसको भी शिफ्ट करेंगे। इसके अलावा हमारे पास और कुछ चीजें नहीं है तो हम लोग अपने कमर के बेल्ट का भी स्ट्रेचर बना के उसको कैजुअलिटी को शिफ्ट करते हैं। एक अपने ले लो, अपने ले लो। जनरली हम लोग रेस्क्यूअर हमारे बेल्ट यूज नहीं करते कि आपके ही बेल्ट यूज करते, क्योंकि आपको लगे कि हमारे बेल्ट मजबूत रहते, इसलिए आपके बेल्ट का यूज करना चाहते। अभी दो मिले, दो और मिलेंगे तो बहुत बेटर हो जाएगा। किसी के भी दो बेल्ट मंगेश, जल्दी और पीछे, हाँ स्टार्ट करिए, सो जाओ लंबे। करना बेल्ट, सो जाओ। एक पैर के थोड़ा और पीछे करो, क्रॉस में पकड़ो, बखल के पास नहीं पकड़ना है, बखल कभी भी निकल सकता है। हाँ, हो गया, रेडी हो गए दोनों, एक पोजीशन में आ जाओ, उठने के बाद हो गया। लिप धीरे धीरे उठाओ, एक साथ एक साथ उठ, एक साथ, जर्क नहीं करना है, लेके जाओ। धीरे से रखो, और थोड़ा पीछे होना था, धीरे से रखो। तो हमारे पास अवेलेबल जो सोर्सेस है उससे हम लोग कैजुअलिटी शिफ्ट करते हैं। हमारा मकसद है डेंजरस जोन से सेफ जोन लेके जाना। अगर ये भी नहीं है तो हमारे पास कुछ रोप मिलता है, तो रोप की भी हम लोग स्ट्रेचर बना सकते हैं। गाड़ी में इस तरह जो भी अवेलेबल सोर्सेस है उससे हम लोग इवेकेशन करते। जनरली इवेकेशन में बहुत सारी चीजें हम लोग अभी लाइव जब सर्विस में थे तो हम लोग इवेकेशन के लिए जाते थे, तो बहुत लोग कम्युनिकेशन का अभाव रहता था। दूसरी बात, स्टेयरकेस से आते वक्त बहुत गलतियां करते थे। कभी कभी तो अपने ऑफिस से या हॉस्पिटल से निकलते समय मोबाइल में बातें करते निकलते कि हम लोग डेंजरस जोन पे जाना है तो कैसे चलना है। इवन बहुत बार ऐसा होता है कि चलते चलते उनके जूते की लेस छूट जाती है, पीछे वाला आता जूते के लेस पे पाँव रखते तो वो गिर पड़ते। ये सारी चीजें जब आपकी डेंजरस बेल बसती तो हम लोग किस तरह आना है, तो ये स्टेयरकेस से आना है तो वॉल साइड और रेलिंग साइड आना है, बीच में नहीं आना है। जो भी हमारी टीम रेस्क्यू टीम ऊपर जाएंगी तो रास्ता वे क्लियर होना चाहिए। बहुत बार ऐसा देखा गया है कि इमरजेंसी स्टेयरकेस में बहुत सारे लोग इमरजेंसी केस तो बना लेते, मगर हॉस्पिटल में जब जाते तो जो कचरा पड़ा होता आपका उस स्टेयरकेस में रखा जाता, तो वो थोड़ा सा वहाँ पे अवॉइड करेंगे। बहुत बार ऐसे हमने हॉस्पिटल में देखे, इमरजेंसी स्टेज के रहती, जो भी पैराफिट होता है उसके स्टेप पे सारा वो कचरा का बकेट सारी वहाँ पे रखी जाती। उसके बाद जब असेंबल पॉइंट में आते हैं तो वो ऐसे जगह खड़े रहिए ताकि आपके जो कैबिन है या आपके जैसा भी नर्सेस स्टाफ है, डॉक्टर स्टाफ है, अटेंडेंट स्टाफ है, वो कितने लोग मिस है ये मालूम नहीं होता। तो ये मालूम होने के लिए हर आदमी ने अपनी रिपोर्ट देना चाहिए कि हमारे ये स्टाफ का ये मिसिंग हो गया। सर ने अभी किंगवेज हॉस्पिटल का जो उदाहरण दिया, वहाँ पे हम लोग रेस्क्यू करने गए थे तो कोई बता नहीं पा रहा था कितने एम्प्लॉयज है, कितने मिसिंग है। जब टोटल स्मॉक के अंदर में हम लोग घुसे तब पता लगे कि 6 लोग और अंदर पड़े हैं, उनको भी हम लोग अनकॉन्शियस पोजीशन में बाहर लाए। तो ये सारी चीजें वहां पे होती है कि अगर हमको प्रॉपर इंफॉर्मेशन देते तो जल्दी से जल्दी हम लोग उसको रेस्क्यू करेंगे और इवेकेट करें। और कोई अभी इसके बारे में और कुछ पूछना है तो पूछ सकते हैं। थैंक यू IMA की तरफ से मुझे यहाँ रेस्क्यू टेक्निक बताने के लिए बुलाया, इसके लिए मैं सर का अभिनंदन करता हूँ, चीफ फायर ऑफिसर का, क्योंकि मैं रिटायर्ड पर्सन हूँ।
Thank you, everybody. I would like everybody to gather for a group photograph. Uchke sir, please. President and secretary also. Gaukar sir. Are organizing, yeah, Shahnaz madam and Manjusha madam, please. I think these are the people who need great round of applause. Please, everybody stand.
We will be conducting a fire drill downstairs near annex building. Those who want to join can please join us there. And next session will be starting here. Thank you so much.
Our second session is divided into two halves. The first half is online lecture by Dr. Adkekar, State TB Officer from Pune. And the second talk will be delivered by Dr. Swarna Ramteke, NTEP WHO Consultant, Nagpur Division. So for this session, the chairpersons will be Senior Epidemiologist and HOD Community Medicine, GMC Gondia, Dr. Subhash Thakre, and Associate Professor Community Medicine, Dr. Sushma Thakre, who is also IMA AMS Chairperson.
सुरू करायचं.
Thakre sir. Online.
He's online.
He is online.
आमची इंट्रोडक्शन झाली का? बरं बरं. Honorable IMA President, Secretary, senior IMA members, and all organizing committee. And today's important speaker, Dr. Adkekar, Ramteke Madam. Today, we will be talking about a very important topic, which is having a very important public health concern, that is tuberculosis. Every practitioner deals with tuberculosis every day, but still we are miserably failing in controlling and combating tuberculosis. There are multifactorial reasons for controlling difficulties related to tuberculosis. Today, we should know about what are the current Government of India's and Ministry of Health and Family Welfare's guidelines to control and combat tuberculosis. In terms of, we know that tuberculosis is very simple disease caused by Mycobacterium tuberculosis and very easily transmitted by droplet and airborne. And since our childhood till date, we came to know that we are having an effective treatment and preventive measures for tuberculosis. A lot of things had been done related to tuberculosis, from controlled to stopped to end tuberculosis. Now we have reached at a stage of elimination of a tuberculosis. Recently, our Prime Minister has given an additional, what I can say that, inputs for controlling the tuberculosis through National Tuberculosis Elimination Program. I am very happy to introduce Dr. Ram Adkekar. We had been an alumni of Ramananda Swami Tirth Rural Medical College, Ambezogai. He had been worked as a medical officer in different districts across Maharashtra. He had been joint director. Now he is an additional district health officer to district health officer at Kolhapur. And while working as a district health officer at Kolhapur, he made 11 primary health center accredited NAVH. This is a very important step he has taken. Now he is working as a joint director of health services, TB and leprosy. He will be speaking about national tuberculosis elimination, its introduction, national strategic plan initiatives in Maharashtra. I request Dr. Ram Adkekar to say and start his deliberation.
May I request you please make me host so that I can share my PPT. Am I audible?
Please share. Please share presentation, sir.
Yes, that is what I am requesting. Please make me host so that I can share my PPT.
Oh,
Please make me host.
okay.
Yes, sir. Sir, you are co-host now.
Yes. I have shared my PPT. Is it visible?
Sir, it is visible and you are audible. Thank you, sir.
Okay, thank you. Honorable Chairperson and all the delegates, thank you very much for my introduction. So I will make a brief presentation on National Tuberculosis Elimination Program and Policy Updates.
Sir,
So content of my presentation is TB burden, NTB targets, National Strategic Plan 27-2025, policy updates on NTB program, private sector engagement and role of IMA, and way forward.
Hello. Sir, please make slideshow of your presentation.
Okay.
Sir, you are not visible actually.
I'm not visible?
Yeah, yes, sir, you are not visible. Your PPT is visible, but you are not visible.
Okay, my
Camera on.
my video is on. I think I should be visible, but I will check.
Okay,
But
sir,
can
you can continue. No problem.
Yes, thank you. Thank you. So as all of you are aware that TB is one of the most important cause of death, and to be specific, it is one of the top 10 causes of death and the leading cause from a single infectious diseases. So if you look at the most common causes of death, here tuberculosis is one of them. So that's why tuberculosis is very important, and Government of India and WHO, all of them are focusing to end TB by 2030 as per the Sustainable Development Goals. But Government of India has taken a decision to eliminate TB by 2025. So if you look at the TB burden globally and at India level, here if you see the incidence of TB cases, globally more than 10 million cases and 130 per lakh per year TB cases are being detected. But in India, the incidence of TB cases is 2.6 million and 193 cases per lakh per year are detected. And the contribution of India in global incidence of TB cases is 26%. So this is a very high. So India's contribution in TB incidence is very high. Another important indicator is mortality of TB. So globally, 1.2 million deaths due to TB occur, and in India, around 4,36,000 TB deaths occur. and the contribution of India in global mortality due to TB is 36%. Again, this is very high. MDR TB patients, the India's contribution is 27%. And all of you are aware that Mumbai and Thane, these are the areas where MDR TB patients are very high. And again, children with tuberculosis, India's contribution is 28%. So these are the 4 indicators which clearly indicates that India needs to take drastic actions to reduce incidence, mortality, and MDR TB and children with tuberculosis. If you look at the dynamics of the TB, all of you are aware that the TB patient is the source of infection, and through close contact, this disease gets spreaded, and one patient with infectious pulmonary TB can infect 10 to 20 persons in a year if left untreated. And what causes the infection into TB disease? The most common factors which contribute are malnutrition, low immunity, HIV, diabetes, tobacco, alcohol. The TB disease from TB infection, here lifetime risk is 10%, and this risk increases due to comorbidity, and the important comorbidities are HIV. Here in case of HIV, the risk increases by 60%, and in diabetes mellitus, it increases by 30%. So TB is not a disease which can be controlled by only health disease. There are many factors which are contributing to the TB, that is poverty, malnutrition, and different sectors which are very important and needs to work together. They are health, mines and industries, food, civil, social justice, tribal welfare, rural and urban development, women and child development, environment, and again, overcrowding, poor housing, indoor air pollution, migrants, tribal, diabetes, HIV, smoking. All these factors contribute to the incidence of tuberculosis, and that's why this disease cannot be managed by health department only. All these departments need to come together and work in a very systematic and coordinated manner to achieve the end TB goals of 2025. Here, if we look at end TB goals by 2035, reduction in number of TB deaths, it is expected to reduce 95% from the baseline data of 2015. So from 2015, we are expecting to reduce number of deaths due to TB by 95%. But sustained development goals, it is 90%. And India has decided to achieve the SDG goals by 2025. So we need to achieve the goals which are expected to achieve by 2030. Reduction in TB incidence by as per SDG goals by 2030, we need to achieve 80% reduction, and same for India is by 2025. If we want to achieve 80% reduction in tuberculosis by 2025, then we need to reduce our TB incidence per lakh population 44. So per lakh population, we need to come down to 44 TB cases per lakh population per year. Right now, we are around 190. So huge work we need to do. TB affected families facing catastrophic costs due to TB patient. So it is expected 0. And as I already explained, India planned to achieve 2030 SDG targets of TB by 2025. So Honorable Prime Minister has taken this ambitious decision to achieve end TB by 2030. These are the SDG goals and India has taken a policy decision under the leadership of Honorable Prime Minister to achieve these goals by 2025. So this is the vision. Then goals we have already seen. Objectives are build, strengthen, and sustain an enabling environment for TB elimination, prevent the emergence of TB in susceptible population, detect all TB cases in the community at early, treat all TB cases with quality treatment, care, and support services. So this is the National Strategic Plan 27-20-25. These are the thrust areas, private sector engagement. So this is very important. Unless we engage private sector, we cannot achieve our 2025 goals. Then active case finding, all of you are aware that in Maharashtra, we have started from 15th November, active case finding. That active case finding will be for 10 working days from 15th November to 25th November. In these 10 days, we are covering vulnerable group, that is around 1.75 crores. So through our search teams, we will be visiting vulnerable group. Then based on the symptoms, we identify presumptive cases and we refer them for diagnosis, and after diagnosis, we put on them on treatment. TB comorbidities, you know, TB HIV, TB diabetes mellitus, TB alcohol, TB tobacco, TB COVID. These are the comorbidities we need to look into, and government of Maharashtra has already taken a decision to work for all these comorbidities. Multi-sectoral response. We have already seen TB disease cannot be controlled by health department only. All departments need to come together to achieve our 2025 goal. Drug resistance TB. For that, we do universal drug susceptibility test, shorter regimen, DST guided treatment, newer drugs, bedaquiline and delamide, ICT tools for adherence and monitoring, and preventive measures, contact screening, airborne infection control, and prophylaxis. These are the main thrust areas of our National Strategic Plan 2017-2025. So how we are progressing towards our NTB goals. So in 2015, our TB incidence was 217 per lakh population per year, and by 2020 we were expected to reach up to 142, and by 2025 we have to reach up to 44. Then only we can say that we have achieved NTB goals by 2025. But how our current progress? This is the trend line. We have to reduce our TB incidence, but we are not reducing as per expected level. So we need to work very hard to achieve our goals of NTB 2025. So if we go in this way only, so we may be around 160, 170, but we have to reach up to 44 per lakh population. So if you want to reach, then what initiatives we need to take? We have already seen in our National Strategic Plan. Again, we will discuss about it in our further slides. So what are the challenges in achieving NTB goals? Underreporting and uncertain care of TB patient in different sectors, particularly Schedule H1 implementation, reaching the unreached slums, tribals, vulnerable group, then drug-resistant TB, comorbidities, undernutrition, overcrowding, lack of awareness and poor health seeking behavior, which lead to delay in diagnosis, wide geographical variation in the epidemic. So what are the steps taken to overcome these challenges? Advanced directives to ensure continuity of TB services from Government of India, Government of Maharashtra, implementation of bidirectional TB code screening. So in our next slide, we will see how COVID pandemic has impacted our TB incidence. And that's why Government of India Central TB Division had come up with the bidirectional TB code screening. All patients of ILI, SARI, and COVID, they have to undergo for TB diagnosis, and patients of TB, they have to be tested for COVID. And because of the bidirectional TB code screening, we could detect thousands of TB cases. Then guidance on TB diagnostic labs to remain functional, integrated TB COVID laboratory services, decentralized molecular diagnostic at block level for TB and COVID screening and upfront molecular testing. We know that sensitivity of microscopy as compared to molecular testing is very, very poor. That's why Government of India and Central Division has taken a policy decision to scale up molecular diagnostics at block level. Right now, we have 147 CBNet machines and 79 TrueNet machines. But next 1 year, we will be procuring more than 300 TrueNet machines and CBNet machines so that we can reach up to every block in the state. Effective sample collection and transportation system. You all are aware that this is a major challenge to transport samples from village, subcenter level to designated microscopic centers. Then active TB case finding campaign, just now I have talked about it. Contract tracing for close household and workplace contacts, home-based sample collection, and provision of at least 1 month supply of drugs to the patient's doorsteps. So this is the status of TB services in Maharashtra. As far as the NTP, National Tuberculosis Elimination Program, is concerned, we have 80 units. So we call them district corporations, then districts, and Mumbai Corporation itself has 24 districts. In this way, in Maharashtra, for NTP, we have 80 units. State TB and demonstration center, we have 3 centers, Pune, Nagpur, and Mumbai. Then tuberculosis unit 529. Then the DMCs 1935. Culture and DST labs 12, including IRL private labs. Right now we have 5 public labs and 7 private labs. CBNet machines, I already told 147. We have some TB hospitals. So these are the different services which are available. So this is the data about the key indicator. If you look at the total TB cases notified, in 2017 we were below 2 lakh. In 2018 we just crossed 2 lakh, and in 2019, which was our highest TB notification, which was 2.27 lakh. But in 2020 we could notify only 1.6 lakh tuberculosis cases because of the COVID pandemic. But this year, we, in spite of severe COVID second wave, we could overcome very soon, and we could achieve 162,000 cases as on today, which is more than last year's entire year's achievement. So we are expecting to reach 2 lakh cases by December 2021. So if you look at the key indicator, the success rate, which was 84% in 2020, right now it is 86%. TB cases known their HIV status, comorbidity, it is 94%, and diabetes mellitus status known is 93%. So this is how we are focusing on comorbidities. So we are expanding our diagnostic facilities. So diagnostic algorithm for pulmonary TB, all of you are aware that for every presumptive TB patient, he has to undergo smear examination and chest X-ray. And for PL HIV patient living with HIV, when we can directly refer for CBNet, because the sensitivity of CBNet and TrueNet is very high. So after smear examination, we can decide whether the patient is microbiologically confirmed or not. And one more thing is that every presumptive case or suspect case of TB has to undergo for chest X-ray, and for that purpose, we have expanded our chest X-ray services. We have chest X-ray facilities in our rural hospitals, sub-district hospital, district hospital, and again we have outsourced X-ray facilities so that we can refer all our presumptive cases to outsourced facilities also, and we can get their X-ray as soon as possible. Then again for the pediatric pulmonary TB cases, we know that chest X-ray is also very important. When chest X-ray if highly suggestive, then we go for export sputum collection, and then based on the diagnosis with CBNAT, then we come to know whether that case is of tuberculosis or not. In case of pediatric presumptive cases, we usually advise and we focus on CBNAT or molecular testing so that we can diagnose them very earlier stages. Then we already talked about the CBNAT. Then biological specimen sample, we know that we transport sputum samples from village level, subcenter level, non-DMC PEC level to DMC through Falcon tubes and in cold chain, then reaching missing cases for TB notification. So we know that last year, due to COVID pandemic, we could detect only 1.6 lakh cases. This year, we have already detected more than 1,62,000 cases. So still there are missing cases. How these missing cases can be detected? Private hospitals, clinics, and chemists. These are very important. That's why such type of conferences which involve medical practitioners, and through them we can identify missing cases, intersectoral coordination, major TB laboratories, house-to-house survey in community, public hospitals. So this is about the impact of COVID pandemic in 2020 at national level. If we look here in the month of February, March, especially in March, there was decline of 51%. So in TB notification, we know that COVID started in the month of March 2020, and because of that, our reduction in TB incidence was 51% because we could not detect all the cases in the community. That's why our TB notification impacted. This is the Maharashtra data. This is the slide which shows how COVID pandemic impacted TB case notification in Maharashtra. So this is about the January, February, March. So in the month of April and May, see how our TB case notification impacted. There was around 55% reduction in TB case notification in Maharashtra, and it took many months to get back to pre-COVID level. Only in the month of December 2020, we could notify around 19,000 TB cases because of the involvement of private sector and active case finding during entire month of December 2020. And because of that, from April to November, we could not detect TB cases as per expectation, and we can say that definitely there were missing cases in the community. So what is the situation in 2021? Again in 2021, from January to March, we were detecting more than 15,000 cases per month. But again, second wave of COVID started in the month of April, and in the month of April, there was decline in TB case notification by 36% as compared to March 2021. So in April, we detected 11,000, and in May, we could detect less than 11,000 cases. But after that, we could get back to our normal notification in the month of June itself, because of the continuous focus on bidirectional TB COVID screening, then active case finding, then continuous review of public sector notification, private sector notification through JIT and other patient provider support agencies. And in the month of October, we could detect more than 18,000 cases. So there is lot of potential in Maharashtra to identify maximum number of TB cases. So what were the mitigation measures adopted during pandemic? Directives for interrupted TB services, bidirectional TB COVID screening, telemedicine and ACF, PPs for staff and doorstep sample collection, timely release of benefits under Nikshay Poshan Yojana, and e-trainings and periodic reviews with states and district. Because of that, we could achieve these indicators which we have already talked about, but only indicator I would like to draw your attention is Nikshay Poshan Yojana. Here we give 500 rupees to each TB patient during his treatment period. This is for patients in public and private sectors also. Here, private practitioners through IMA, they can encourage patients to take this benefit, that is Nikshay Poshan Yojana, and it is direct benefit transfer. So strengthening case finding, these are the areas in public we are focusing. As far as private sector is concerned, expansion of patient provider support agency. Right now, we have PPSA in 24 districts of Mumbai and 11 districts and corporation of Maharashtra. Nagpur is one of the corporation where we have PPSA. But in the PIP of 2021-22, we have included all the districts so that we can scale up this PPSA activity. Mandatory notification gazette. So it is mandatory for all the private practitioners to notify TB cases, schedule H1 surveillance, corporate sector involvement, incentives for providers and informants. This is for private sector informants also. So drug resistance TB, I will be very fast. I think I have taken much time, but I will not take much time. I will be fast. UDST. So this is very important. Universal drug susceptibility test of all patients. As soon as we diagnose them or we notify them as a case of TB, they have to undergo UDST. Then we can identify for which drug this patient is susceptible. Based on that, we can start the regimen. So this is very important. I request all the private practitioners to ensure that all TB patients undergo a UDST. So molecular testing, we have already spoke about it. Overview model of care in drug. We know that in every district or regional level, there is a DR TB center, at district level TB center and nodal DR TB center. Then initial hospitalization, complete ambulatory care, follow-up protocol. We know that health facilities then identify the patient to offer NAT testing, LPA, DST. We have already spoke about. We have NAT facilities and LPA at our STDC, and we have 12 culture and drugs susceptibility labs. And treatment services. Now there is a paradigm shift in the management of drug resistant TB. Shorter oral BDQ, MDR TB regimen. We know that all MDR rifampin resistance TB patient without resistance to second line drugs, BDQ containing regimen, MDR RR TB patient resistance to second line drugs, delanamide containing regimen for 6 to 18 years. All oral longer regimen, MDR TB patient not eligible for shorter MDR TB regimen. So this is about the bidirectional TB code screening. Nikshay Poshan Yojana, we have already spoken about it. Then you know about the Nikshay web-based case-based software. This is a very comprehensive software. All the TB patients notified have to be entered in Nikshay, and on one click we get district-wise, region-wise, state-wise, block-wise number of patients detected and other services provided to TB patient. So this is a very good software. Other sector engagement, we have already spoken about that, but a brief level mention community engagement. So there are TB forums set up at the district and state level on regular basis. We conduct their meetings. TB survivors are mentored to become TB champions. At every block, we have identified at least 2 TB champions. With the help of them, we try to reduce stigma in TB patient, engaging with corporate sector and latent TB infection management. This year, we have taken up 50 districts for TB preventive treatment or LTBI management. So this is going to be a very big program, and we will definitely request private sector, then IMA to help us in this initiative. So I hope that we can work very systematically on latent TB infection program. Here we visit all the pulmonary TB patients' contacts, and we screen them with the help of IGRA testing and chest X-ray, and based on them we exclude a TB patient and then we put on them on INH. So newer initiatives to be rolled out under NTPR, PMDT guidelines, PMTPT, just now I spoke about it, programmatic management of TB preventive treatment, then Jan Andolan, way forward, transition from sphere microscopy to upfront rapid molecular testing, improving linkages with the general health system and NHM, RBSK, RKSK, Health and Wellness Center, vulnerability mapping, scale up of latent TB infection, then PPSAs and community engagement. So this is the IMA resolution. Private sector engagement. So this is about the TB notification gazette. So what are the expectations from IMA? Early diagnosis of TB cases according to diagnostic algorithm. So this is very important. We know that anyhow TB patient will be diagnosed. No doubt about it. If he has cough for more than 2 weeks, fever, then significant reduction in weight, then hemoptysis, these are the symptoms which take patient to the doctor. But if we diagnose them in the earlier stages, at early stages, we can definitely prevent or stop transmission of TB disease. We know that every untreated TB patient transmit disease to 10 to 15 healthy persons. Treatment initiation according to programmatic treatment regimens, UDST, CBNet, LPA testing of all cases, notification of cases, and then Nikshay ID, then providing them DBT, public health action support for contact tracing HIV and diabetes mellitus, diagnosing LTBI, microbiological confirmation of clinical diagnosis. I think this was very short presentation about NTP program. If we have any additional, if any thing to be discussed or any queries, I am very happy to answer to queries of any participant. Over to organizers, please. Thank you.
Okay, thank you, sir. We recognize the presence of past president, Dr. Y.S. Deshpande, he was president IMA of Maharashtra State. Welcome, sir.
Dr. Adkekar has very nicely explained about the current situation to combat tuberculosis. No doubt, he has explained very nicely the role of Government of India, Center for TB Control, Ministry of Health and Family Welfare, role of Government of Maharashtra, and we should not forget these guidelines are being designed on the basis of evidences generated by a lot of research. Tuberculosis is treated as per my own wish and whim. Our Prime Minister is thinking for universalization of healthcare. Universalization of healthcare means from detection to complete treatment to further support of tuberculosis should be at a free of cost. Not a single penny since beginning should be spent from their own pocket. And this should be actually practiced on the basis of evidences. These guidelines, all doctors should go through these guidelines. All patients must be subjected to not only radiological investigations, not only microscopic, but the CBNAT. CBNAT we have used for this, what is that? Epidemic? COVID. CBNAT used. And United States, $20 million now foreign funded. Again, we are going to procure those machines as sir stated. Those machines will be utilized for early detection. And detection is not only useful, but for which drug to be given to those ones. Proportionately, 9 to 10% of that multi-drug resistance tuberculosis patients are there. अगर असे पेशंट जर आपल्या समाजामध्ये फिरत राहिले तर याचा ड्रगची ट्रीटमेंट खूप कॉस्टली पडणार आहे. सरकारला ते परवडण्यासारखं नाही राहणार आहे. जास्तीत जास्त बजेट त्याच्यासाठीच जाणार आहे. आणि दुसरा महत्त्वाचा मुद्दा म्हणजे आपल्या सगळ्यांवरचा लोकांचा विश्वास कमी होऊन जाईल. हे टीबीची औषध डॉक्टरांनी दिली, आमचं काही बरं झालेलं नाही आहे, लंग्स खराब झाले आहे, मंत्र मारा, पाणी मारा, अंगारा खा, आणि मग ते पेशंट मिस होतात. पब्लिक हेल्थ एक्सपर्ट ऐकत असेल ते लोक मिस होतात आणि मिस झाल्यामुळे ते समाजामध्ये तसा डिसीज पसरत असतात. नो डाऊट दिस डिसीज इज हॅव्हिंग ए बायोलॉजिकल कॉज, बट सर्टनली दिस डिसीज इज हॅव्हिंग ॲज पर मिलेनियम डेव्हलपमेंट गोल, सस्टेनेबल डेव्हलपमेंट गोल 3 पॉवर्टी रिलेटेड टू मालन्यूट्रिशन. HIV ने खूप कहर केला, त्याच्यामुळे ट्युबरक्युलोसिसला कंट्रोल करण्यासाठी आपल्याला खूप अथक प्रयत्न अजूनही करावे लागणार आहे. त्याच्यात आता हे नवीन आलं आहे डिसीज पॅन्डेमिक, त्याच्यामुळे अजून टीबीचे काय परिणाम होतील ते आपल्याला सध्याशी सांगता येणार नाही. परंतु सरकारने या डिसीजला कंट्रोल करायसाठी त्याचा टीबीसाठी सर्टनली आपण फायदा करून घेऊ आणि टीबीला आळा घालण्यासाठी मदत होईल. मला असं वाटतं डॉक्टरांनी आपल्याला बऱ्याच गोष्टी सांगितल्या, त्या सगळ्या सायंटिफिक आणि टेक्निकल होत्या आणि आपण सगळे लर्नेड लोक आहे, त्याच्यामुळे आपल्याला समजण्यासाठी काहीही कठीण गेलेलं नाही आहे. टीबीला आळा घालण्यासाठी आपण शपथ घेऊ आणि टीबीला संपूर्णपणे नष्ट करण्याचा आपला प्रयत्न राहील, असाच आपण प्रण करूया. आता याच्यानंतर एनी ऑनलाईन क्वेश्चन्स पर्टिनंट? डॉक्टरांना मी एक प्रश्न असा विचारतो की ट्युबरक्युलोसिस एंड करायचा आहे. व्हॉट आर द हाऊ मेनी डिस्ट्रिक्ट हॅव रीच टू इलिमिनेशन स्टेज इन महाराष्ट्र?
थँक्यू सर, अत्यंत चांगला प्रश्न आहे आपला. सर हे 2020 मध्ये आपण सर 8 जिल्ह्यामध्ये आपण 20% रिडक्शन केलेलं आहे, की जे आपलं गोल आहे 2025 पर्यंत करायचं. आणि कोल्हापूर डिस्ट्रिक्टमध्ये सर आपण 40% केलेलं आहे. म्हणजे 9 जिल्हे सर की आपले ऑलरेडी टीबी इलिमिनेशनच्या त्या रेसमध्ये पुढे आहेत आणि देशामध्ये सर्वात जास्त जिल्ह्यांना की हे टीबी फ्री अवॉर्ड मिळालेल्या जिल्ह्यामध्ये महाराष्ट्र आहे. सर आपण 9 जिल्ह्यामध्ये सर आपण 20%नी 2015च्या बेसलाईनच्या आधारावर आपण हे अचीव करू शकलेलं आहे.
थँक्यू. एक अजून प्रश्न आपल्याकडे आलेला आहे. व्हॉट इज द RO फॉर ट्युबरक्युलोसिस? काही एक्सप्लेन केलाय त्यांनी काही एक्सप्लेन केलं नाही असा एक प्रश्न ऑनलाईन आलेला आहे आपल्याकडे. व्हॉट इज द capital O capital for tuberculosis.
RO.
मलाही माहित नाही. मला माहित असेल तर सांगा.
काही आयडिया आली नाही.
नाही काही idea.
फर्दर सर तिथंच आमचे WHO कन्सल्टंट पण आहेत. मला वाटतं त्यांचं पॅरलल लेक्चर चालू आहे. काही याच्याबद्दल अजून काही क्वेरीज असतील तर त्या ठिकाणी डॉक्टर रामटेके म्हणून
नाही आहे
त्यांचं-
माझ्या समोरच बसलेला आहे पण त्यांना नंतर विचारील मी हा प्रश्न.
हा. मला काही
Pending
कळलं नाही
ठेवतो.
सर.
हा.
No question. So, I would like to
Yes.
invite chairpersons to felicitate
Thank you,
Dr. R.K.
Dr. Ramji.
Thank you,
for
sir.
your-
by
Thank
showing
you very
them
much.
the memento.
Thank you very much, sir.
You are requested to accept online memento.
Yes, sir. Yes, sir. Thank you, sir. Thank you. Thank you very much.
Now I would like to invite our next speaker. She is Dr. Swarna Abhimanyu Ramteke. She will be delivering her lecture on NTEP performance of Nagpur district, NTEP services and cooperation expected from private practitioners. She is the alumni of GMC Akola. She has done her post-graduation in SET, GS Medical College and KIM Hospital, Mumbai. She has worked as medical officer in Bhandaras from 12 to 15, and she was also in my college, IGGMC Nagpur. She was bonded candidate at that time. She has substantial publication at her record. She is working as consultant WHO NTEP Nagpur division. She assists the division in implementation of NTEP guidelines. She collect and do the analysis of NTEP for review and action. She is strengthening and she is doing capacity building of staff at State TB Cell. She facilitated the training of drug resistance tuberculosis. So please welcome Dr. Swarna Ramteke.
Good afternoon, everyone. I'm Dr. Swarna Ramteke, WHO National TB Elimination Program Medical Consultant for Nagpur Division. I've recently joined in October. And all the vital dignitaries on the stage and all the delegates. So I sincerely thank everyone to offer me this platform to share my views on this program with you. I'll be starting with the introduction about the Nagpur district and the National TB Elimination Program status in the district. But before going into that, what we'll be trying to think upon is that the scenario that STO sir just has presented, that we are actually dealing with a very difficult, or you can say a grave situation right now. In our country, as that we are sharing a burden, like sir has projected, 26 lakh cases we are looking for to diagnose, but since the COVID has happened and we are actually lagging and there are so many of missed cases out there. So it's an onus in the private sector right now that whatever missed cases are there, already as a public sector, we are already working hard to get those missed cases on board. But the private sector has been playing a huge role in diagnosing and treating the TB cases. So that's what we are here to discuss about. So let's start with the introduction. The Nagpur Corporation has been an example because, let me tell you that Nagpur has been a district where so many innovations have been generated since past, like right from the beginning, to say like 2017, we are trying to deal with the private sector and we are doing very well in the program. But since there are so many things that we have to still, work upon, there are still so many gaps we have to bridge upon. But since you all know that Nagpur being a medical hub, we are catering to so many states, especially the MP, Chhattisgarh, Jharkhand. So we have actually owners of other states as well, because they are coming and looking up to us to diagnose and treat them. So since I have been saying that we have been making an immense progress in the program, but now we are in a mission mode. No, 2025, we are looking forward eliminating TB. So we have to put on immense efforts other than what we have been right now doing it. Like I can tell you that active case finding is something that we have been practicing very, very deliberately, so that the patients that we have missed in the community in COVID pandemic, we are trying to get them on board. So these are the very intensive efforts by the government to diagnose the missed cases as well as put them on treatment. So right now I'll be talking about the private sector specifically. So private sector, you all know in India 80% of the people seek care in private sector. And if we see the data for Maharashtra, you can see it's 1.5 is the ratio that goes for the private sector. Is the huge amount of the patient, that bulk load that goes to the private sector, and especially a Nagpur corporation, where all the kinds of cases we deal with and the cases from the neighboring districts that they come to us. So what happens is, what we are trying to do here is, being a doctor, we are trying to look or adhere to the standards of TB care in India. What we're trying to do is get the patient on board, get the patient notified, get the patient all the necessary services, as well as on treatment, appropriate regimen. That is the concern. That what we see is, in general, what happens is, in the private practices, conventional regimens are still being used. But there are guidelines that say that conventional regimens has lesser success rate. So that's why we are trying to promote here that we have to go by the guidelines. So this other slide that I have been trying to project here has already been covered by sir, but I'm re-emphasizing upon it because we have this agency which has signed an MOU with government of Maharashtra, and we are trying to engage with the private sector doctor with the help of this agency. And we have this agency with us that has been helping us with all the diagnostic facilities as well as the treatment facilities to be, there in the system, and especially in order to make sure that the confidentiality of this private patient should be maintained. So it's not the private sector, if the corporate sector we are trying to involve, and not only not just for the sake of the treatment or diagnosis, but as well as we are trying to get the funds out of them so that we can have a better diagnostic services disseminated to the peripheral level. Like sir has just mentioned a few minutes back, that we are trying to procure CBNAT machines, cartridge-based nucleic acid amplification test machines, TruNAT machines, so that at every block level we'll have one CBNAT machine. Let me tell you, in CBNAT, you need only 50 to 100 bacteria in 1 ml to diagnose a TB. But when we say microscopy, you require 6,000 to 10,000 bacteria in 1 ml of sputum to diagnose TB. So you can tell how sensitive and specific is this stage. Both TruNAT as well as the CBNAT I'm talking about. The molecular diagnostics are really, are kind of forerunning this program. And right now we have in CBNAT, we have 10 color modular machines. You all know, when we subject the sputum sample to CBNAT, we can detect Mycobacterium tuberculosis. The other thing we detect is the rifampicin resistance, right? That is what we call as universal drug susceptibility testing. So, but what about this 10 modular machine will be able to diagnose pre-XDR as well. So in one go, you'll be able to have a resistance pattern of that patient in one go. So that's something I'm trying to disseminate over here, that UDST is something very, very important. And in private sector, that is something we're trying to emphasize upon. When you write about HIV and diabetes testing for every patient, for a presumptive TB patient, when you think that this is a presumptive and you write down HIV and diabetes status to be known, please, please, please write down the UDST, because it is free. It's free of cost. It's with us. It's not only CBNAT, we have LPA, line probe assay, first line, second line, as well as first line, second line liquid culture DST is again free. But this needs to be done. This needs to be streamlined, because we have all these diagnostic facilities with us and free of cost. But only thing you have to do is you have to just write down when you prescribe, so that the patients will get all these services free of cost, and will know that resistance pattern of the patient, and then only will be able to give them appropriate regimen, We'll be modifying the regimen according to the resistance pattern of the patient. And that's why it is important that I'm trying to tell this, that CBNAT, TrueNAT, line proboscis, liquid culture DST, please try to write it down when you try to advise a presumptive TB patient. So that's what I tried about to talk, like standards of TB care. This has been, again, this is a very wonderful guideline and has been made by IMA people only. So obviously we expect IMA people to adhere to this and stick to these guidelines, right? So what happens is that we all know, especially when we say to diagnosis, when we say about treatment, what are we trying to say about diagnosis? Like the sir has said, diagnosis for a normal patient, we look for microscopy and chest X-ray, right? But in the private sector, what we are seeing, we are looking for an upfront CBNAT because we want our precious patient to get a right treatment early as possible, right? So, but again, what we are trying to see here is when we put on a patient a treatment, please try to ensure that you give a proper regimen. Proper regimen, intensive phase, continuation phase, 6 months. Please don't try to use it as an empirical treatment for something like for 2 months, let's try for 3 months. No. See what will happen now if you give for inadequate amount of duration if your treatment is being given, what will happen? We ultimately are trying to create a resistance, an amplification of resistance in the community. So that's why it is important that when we are prescribing a person any anti-TB drugs, please make sure it is for 6 months only. Then only we'll be able to fight the resistance pattern. Otherwise, we will be only responsible for converting that drug-sensitive TB patient into a drug-resistant case. So that's why it is important that you stick to the duration. So what are this treatment regimen that I'm trying to talk about? Drug-sensitive TB test. So first initial phase, 4 drugs that we are trying to give for 2 months, isoniazid, rifampicin, pyrazinamide and ethambutol for 2 months, and HRE, isoniazid, rifampicin and ethambutol for 4 months. Although continuation phase can be extended for 3 months for like extrapulmonary cases or special situations like bone and joint TB, spinal TB or neurological involvement. Again, it's a doctor's call to decide upon the duration of the treatment, that's okay. But thing is, at least stick to this regimen. Just don't try to curtail the duration of the treatment, only just to see if it works or not. Similarly, you all know that we have the guidelines have been shifted from intermittent regimen to the daily regimens, and we are giving fixed dose combinations, right? And this is very important. Likewise, again, I'm emphasizing upon the CBNAT test as well as the LPA testing that you should try to incorporate in your advice. So let's talk about the private sector engagement. When we talk about the Nagpur, so many pilot projects that I've said we have started. So since 2017, we have started with many projects. And to make sure that this works also, we have Disha Foundation with us working, and it's still working with us for except resource as well. The JEET PPSA Lite has been working with us, but now we have another agency which is called as HLF PPT. Again, we have one more organization working with us, that is Akshaya Project. This is a union project, and it's work for programmatic management of TB preventive treatment. Sir has just highlighted a bit of it. For latent TB infection, the program has gone one step before. Like you all know that 35 to 40 crores of Indians are already TB infected, right? But it's just that we don't have signs and symptoms. The disease has not manifested yet, and we have a good immunity status, and that's why we are roaming around freely. But now what program is trying to do is trying to identify these people with infection and put these people with infection on treatment. So let me tell you, TB infection and TB disease will be two other different components, right? TB disease will be giving AKTs, but for TB infection, we have TPTs, TB preventive treatment that has been rolled out in our Maharashtra. And let me tell you that Maharashtra is a state that has also, starting with the regimen that has not been started in anywhere in the country. That is 3HP. Where we'll be giving isoniazid and rifampicin. See, rifampicin is the drug we'll be using for the first time. And this has been recently DCCI approved. So these are the regimens that we are trying to roll out in our state. So first will be 6 monthly isoniazid and the 3 monthly HP. See why I'm trying to say all these things over here, because these are the new things in the program. And that should drill down to every private practitioner, to every IMA member. Because when we think of controlling TB, when we think of eliminating TB, we need to reach out to every person who is infected. Otherwise, what will happen? Every time a patient comes to you, is diagnosed, you are treating the patient. Until then, if you are not diagnosing the patient early, till then the patient has spread infection to so many people. You all know that a single TB patient spreads, makes 15 different TB patients in a year if left untreated. So 15 TB patients has been made by a single patient, right? So what we'll be doing? Again, we'll be diagnosing those 15. Again, we'll be putting them on treatment. So this vicious cycle is going to continue. We don't want this. Parallelly, when we're trying to put the patient on treatment, we're also trying to identify the people with infection. So our main criteria for these people are the beneficiaries are the household contacts. So that's why we are trying to engage with the private sector. We have, like I said, 1.5 times the patients are there in private sector. And that's why we have an agency to get our private sector on board with us. So what is the status of private sector involvement in Nagpur? You can say we have MBBS and above people, and yet we don't know how much the total is, but we have mapped 1532. They are engaged 1208, but only actives are 294. Okay. Similarly, you can see the list that goes on. So what is important that please just not the MBBS, but even the Ayush practitioner, even if they refer the patient to us, it's not that they are supposed to diagnose, just refer. Just identifying the presumptive TB case based on the symptoms and just referring, who can that make that Ayush doctor also an informant, and informant incentive can be given to the Ayush doctor. Like a private practitioner also. If a private practitioner doesn't want to notify, but at least even refer the patient, and that gets identified and notified in the public sector, even that informant incentive can be given to the private practitioner. So there can be, anybody can be an informant. So let me tell you what we have achieved in Nagpur Municipal Corporation National TB Elimination Program status. You could see since 2018, this Nikshay Poshan Yojana has been rolled out April 2018. So we have paid 18 lakhs almost to the private practitioners for the incentives they have been receiving for the notification. And Nikshay, under Nikshay Poshan Yojana, direct benefit transfer, for every month a patient receives 500 rupees, for which we have already, when you can see the number. As well as for the sputum transport for special private patients for SIBNET test, 9,751 patients have been given this service for free. And similarly, private patients for the HIV and diabetes status can be known, that to be freely. And fixed dose combination consumption is 4914 patients. In fact, a program also have a provision that if a private practitioner wants to have that fixed dose combination drugs with them, they can have it. So we can have those drugs with you and you can let the patient have it for free. Only thing we have to make sure that the patient gets the right regimen and the right duration of the treatment. Similarly, this many of X-rays have been done by the Nagpur Municipal Corporation for the X-ray, for all the patients with TB. So you can understand. So this is the data that I'm talking about, only private patients. We have a huge lot number about public patients that we've been catering to. So this needs to, consolidate it. This needs to be, become a substantiate, because otherwise eliminating a TB will be a dream, because we have to get every private practitioner on board. Just have to make sure that identify and presumptive TB, diagnose it or refer it, and then based on get the notification, put on the outcome. So all these things that needs to come in the picture based on the diagnosis of the patient. But then again, we have to do is we have to make sure that we don't miss out on inpatient. We are working right from the ground level, right from the CHO, subcenter, PHC, then SDH, RH, and then tertiary care hospital, to the municipal corporation hospital, to the private sectors. Everything we are trying to involve so that no patient is left diagnosed or notified. So these are the notification trend for the private sector you could see. And you could see in second quarter 20, because of the COVID impact, we have lost. So you can actually a very considerable contribution from the private sector we have been receiving. So what are the services that a private sector can have from National TB Elimination Program? You could see chest X-ray voucher we can have. We can have this CBNAT that I just said, or the TrueNAT. That's all for free. That again will have a notification, and then again we can be putting on the patient, putting the treatment with the appropriate regimen, and that too again free. And we'll be linking all the public health actions, like contact tracing and the HIV diabetes status, as well as the adherence support, that will be done by the public sector. And this is how, if you want to maintain the confidentiality of your private patient, we can just contact them by SMS or phone call. So what a doctor is expected to do? Once the treatment is prescribed, please, we have to identify a treatment supporter. That program mandate is that. But if the patient says, no, I will come to you directly and get the medicine, that's fine. But in program, we try to identify one treatment supporter. For example, in rural area, what they have is ASHA is a treatment supporter, because we have to follow the DOT strategy, directly observed treatment short course. And that's why it is important to identify a treatment supporter, and we give a treatment supporter incentive as well. Similarly, the strips drugs is handed over to the treatment supporter, and then the treatment supporter has to monitor the patient's treatment adherence and everything, as well as any side effect is to be monitored by the ASHA, and the treatment supporter can link that patient to the medical officer or the private practitioner. And as per this, whatever the treatment has been completed and the successful outcome, that is either treatment complete or cured, we declare a patient cured only when we do a final follow-up microscopy, and if it comes negative, we call it cured. So once we declare a patient cured, then the treatment outcome has been entered into the NICSHE portal, and that's how a private practitioner gets more 500 rupees after updation of a treatment outcome. So once 500 rupees for the notification, and the other 500 rupees for the outcome. So that's how 1,000 rupees is allocated for every patient. So this is NICSHE Poshan Yojana that we already have been talking since very long, that this is for patient nutrition component for 500 rupees per month that government has been giving. So this is the incentive that I was talking about, that all the private practitioners that will be receiving 500 rupees per PTB patient on notification, and 500 on reporting of a outcome. Treatment outcome is very important, because otherwise you won't be knowing what has happened to the patient. You have diagnosed the patient, you have notified the patient, you have put on the treatment, but what else? Has the patient completed the treatment or not? Because that is something very important. You all know that we had earlier a sanatorium process, that patient used to be admitted in a sanatorium for like many months together and used to get the treatment. But then based on the studies, we have realized that the patient can be given a treatment and can get cured if you have a directly observed treatment of that patient at home itself. And that's why we are trying, we have come up with this DOT strategy. So if we are there with the DOT strategy, we are supposed to adhere to it. We have to ensure that this is happening in the field. And for that also, that's what we are trying to do is, we are trying to get the outcome on time. So what happens is, every patient once diagnosed, we have supposed to collect a bank details for that. So that's what I've been talking about, PPSA, Patient Provider Support Agency, that has been identified, and that is helping us to engage with the private sector. So this is the goal of the Patient Provider Support Agency, to have access to early, good quality diagnosis and treatment, as well as affordable and convenient to the patient treatment services in time, place, and person. And that is what ultimately the program says. Early diagnosis treatment is an objective of the program. So this is the collaboration that we have done with HLFPPT. So between NTP and private sector that has been talking about. So we have a very different model in this HLFPPT. We have one key person we called as Nikshay Mitra, that will be helping us to find out and get all the this documentation process to be done. When a private practitioner identifies the patient and tries to notify, so all these other things needs to be done. So that will happen based on, with the help of this Nikshay Mitra and with the help of this agency, PPSA. So they'll be helping to increase the TB notification, pre-diagnostics, and offer pre-treatment, as well as other support. Like I said, by phone calls or even house visit can be done. So what is the model you can see? There is an NGO officer, there's a field officer that works and have a regular in-clinic visit of with the private sector patients. So what happens is when this officer meets the clinician on and off, and where the patients are being diagnosed, especially the TB patients are being diagnosed, and there a person is being identified, when we call as Nikshay Mitra. What the person does, this person may be a person from NGO, or a person itself can be from that hospital itself, who's ready to do all these things, and that person will be given the incentives based on the patient. Okay. So what happens once the patient comes to the doctor, and the data is being collected with the NGO or field officer, and this Nikshay Mitra tries to collect all the data as well as try to provide all the services. The sputum transport you could see for TBNet or TrueNet. The sputum transport will be doing by the agency only. And then based on the result, the patient will be given the drugs either in shorter regimen and shorter or all oral longer. You all know that Maharashtra has transitioned itself from the injectable shorter regimen to the shorter oral bedaquiline regimen. Earlier, we used to give bedaquiline only in all oral longer regimen, but now we are giving bedaquiline in shorter regimen for even rifampicin resistant status. So we are in a transition phase, and we are one of the states that is working really hard for it. So that's how, and then once the patient is diagnosed, these people only help with the help of an NTP staff. They put the patient on treatment, and appropriate treatment, again based on the SIBNet and TrueNet as well as the LPA. And similarly, the follow-up is being done. So this is how this agency works upon. So this is the Nikshay Mitra I was talking about. So this can be existing staff of a private healthcare facility, or or even a part of an NGO. It can be. So it has some roles like TB notification, providing health education and counseling, collection of bank accounts, because this can be a tedious for a private practitioner to do all these things. So this Nikshay Mitra will be helping that person. The Nikshay Mitra will be helping the private practitioner. And this is how we are trying to engage a private sector with the program. So all the other diagnosis, all the HIV and the diabetes, as well as the tracking and the recording treatment outcome, as well as all the Nikshay entries will be done by this Nikshay Mitra. So this is something everybody should know. And it will be incentivized for everything. So you can, tell somebody, like, for example, receptionist can be person who can be, made a Nikshay Mitra, provided that she'll be, or he'll be giving this, getting this all much incentives by the NGO. So these are all the specifications of that. So 600 in all per patient. We are also trying to have outsource X-ray facilities, because what we are lagging is the X-ray facilities we have, but we are not able to get our patients on board. So that's why we are trying to have us outsourcing with the private sector to have an X-ray facilities free for our patients. So till now we have 39 private X-ray centers we are engaged with our program with a voucher system, as well as we also have one mobile unit which is utilized for cover X-ray in camps and hard to reach areas. So these are the services that are available with the PPSA intervention with us. Pre-diagnostic, that you all know, pre-daily regimen, patient adherence services, facilitating patient notification, private practitioners, because sometimes it becomes difficult for a private practitioner to notify. So these are agents will be helping you out. Monetary benefit, that is something very important for the nutrition as well as for the private practitioner itself, for the notification as well as for the outcome. And if a patient, a treatment supporter has been identified for that entire duration for 6 months, we'll be providing 1,000 rupees for that patient supporter as well. So these many are the services. But now we are expecting from the private practitioners, from IMA people, especially complete basic information. Because what is happening, you all know that in COVID, what we did, we tried to trace the patient. We tried to have a contact tracing. Similarly, in the TB, it being a very infectious disease, in fact, it's a #1 killer in the country. So we are trying to trace it back. We are doing contact tracing. And for that is something very important. We need to have a complete address. We need to have a running and working mobile number. Okay, we need to have a bank details so that we can give them a proper nutrition money. Okay, we need to give them all these standard, WHO endorsed, these facilities are there. CBNet, TrueNet, LP, all are with us free of cost. And that's why this something again need to come on board. We need to have the HIV status. Why we are trying to get the HIV status and diabetes status of every presumptive patient? Because if we know the patient is diabetic or HIV positive, the diagnostic algorithm changes. Then we shift the patient directly to upfront CBNet or TrueNet. Otherwise, we try to put the patient in a normal diagnostic algorithm, X-ray, then microscopy. But this doesn't happen when it comes to HIV, because in HIV, the TB disease is possibacillary. The bacterial load is very low.
Swarna, we are short of time.
We are done, ma'am. This is the last slide. And these are the things that we, all the doctors or the private practitioners need to mention. So treatment outcomes, support to our staff, that is something very important we are expecting out of all the private practitioners. So it's time to come together to end TB, and we need to think TB to eliminate TB. Thank you very much. Any queries?
Okay, thank you, Swarna, for delivering lecture so excellently. I think you have eliminated all the expectations from the private practitioners, some which I understand is they should follow the guidelines. They must strengthen the case finding. They should follow the treatment and duration of the treatment. And as diagnostic facilities are free of cost, that should be utilized properly.
Yeah, especially ma'am, CBNet and TrueNet should go on board.
Yes,
Otherwise,
yes.
we won't be able to have the resistance pattern. That's why I'm emphasizing upon it again and again.
Right.
Thank
So
you very
now
much.
it's time that audience can ask the question. We are short of time. 1 to 2 questions we will take.
Yes, sir.
I strongly recommend as a senior doctor of the city to forward it to the practitioners of Nagpur. Congratulations.
Thank you,
Sure,
sir.
sure,
Thank
sure,
you very
sure.
much. This is what is expected.
Suvarna, you will find many diseases which are not like or disliked by everyone, doctors as well as community members also. There are some diseases which loved by the people. They are called as a sweet friend, diabetes. It changes the lifestyle of an individual. But as tuberculosis is concerned, it's always associated with isolation, discrimination, depression, and a lot of adverse outcome.
Stigma. Yes.
And started with a conventional regime of 18 months, 24 months to 6 months, and to do intermittent and DOTS therapy within CBNet to all advances provided by research, and WHO and you people are collaborating with the government of Maharashtra and government of India. I think this will be the better approach, provided if we try to seek in participation of pharmacists also.
We have already.
That will be helpful, because over the counter drug selling for their conditions like cough and all. I think
We have, sir, H1 schedule monitoring we
yeah.
have.
This is very nice. Any online question? No question, I think. No question. Thank you. ऑफ द रिकॉर्ड मुझे ऐसे लगता है कि अभी अगर इस तरह से चलेगा अपना कार्यक्रम आप लोगों के साथ में, तो टीबी ऐसी थी कि जिसके घर में टीबी है उसके घर में चोरी नहीं होती थी, क्योंकि पेशेंट रात भर खांसते रहता था, जागते रहता था, उसके घर में चोरी होती नहीं थी. अभी इसके बाद में मुझे ऐसा लगता है कि अपन आराम से सो सकेंगे. उसको कम से कम अभी 4-5 साल ये आउटकम को अगर फुल्ली एग्जीक्यूट किया तो so that then certainly we will have a tremendous achievement, because majority of the health budget is wasted or invested for controlling and combating the tuberculosis. Thank you very much, Swarna.
So there is one question online. Is there any role of gastroscopy?
And that is something, again, a clinician's call, because what we are trying to do is try to get as many samples on CBNet, except for stool sample, urine sample. We can have any sample over the
Okay.
CBNet.
Thank you. Thank you for the enthusiastic lecture, Dr. Swarna. I would like to ask chairpersons to felicitate Dr. Swarna with a memento. I would like our President and Secretary to felicitate Dr. Thackeray, Sir and Madam, both. Thank you, everybody. Our next session is creating and managing trained manpower in healthcare. For this, I would like to welcome our chairpersons, Dr. Shailesh Gahukar, Administrator, GMC and Super Specialty Hospital, Nagpur, and Dr. Nilesh Agrawal, Deputy Director, Administration at Alexis Hospital, Nagpur.
Hello, everyone. I'm Dr. Nilesh Agrawal, and it is my pleasure to introduce and invite Mr. Samir Joshi for the next talk, which is on the topic of creating and managing trained manpower in healthcare. So I invite Mr. Samir Joshi to the dais, please. Mr. Samir Joshi is founder and chairman of Transcender Services Private Limited with an engineering degree and post-graduation in business management. Mr. Samir has more than 27 years of cross-continental industry work experience across India, Asia, Europe, and North America. He was honored with the award of India's most trusted CEO in May 2017 in education industry by World Council and Research Corporation, Singapore. Over to you, sir.
Thank you. So thank you. Very good evening to all NIMACON 21 Management Core team here. Very good evening for the members who are available offline here and of course online, and my co-dignitaries on the dais. First and foremost, I think it's a great day today where we are starting with NIMACON. I think it's Guru Nanak Jayanti, very auspicious day. So my best wishes and greetings to my Sikh friends who are available here offline and some of the friends who are available online. On this auspicious day, taking this as a journey, and the topic which is given to me is I think very vital and critical, especially in the backdrop that we all have passed by and which is ongoing also as our way of life. Everybody calls it as a new normal, right? After being very technical discussions, presentations, and will be going as a technical discussions, presentations, I think the topic which I am going to touch upon is a very general, but yes, as I said, it's very important when we are talking about universal health as a coverage, right? And this is where this creating and managing trained manpower in healthcare, I think is a topic of importance to all of us, all of medical professionals who are into this as a new normal situation. English phrase, which we call it as a man is known by the company he carries. And given the situation and the facts that we have all infrastructure, we have all the skill set and the knowledge as a medical practitioner, the best medical practitioner is known by the trained team that he carries. I think that's the right analogy if we can go by when we are tackling this as a topic. So to begin the subject, I would first spend maybe just 2 minutes on who we are. And I thought it's very crucial because when I was seeing through or running through the entire itinerary of the program, I thought I'm the only odd man out to take the dais as carrying the suffix or rather prefix as Mr. Samir Joshi and not Dr. Samir Joshi. So first of all, thanks for IMA Nagpur platform to allowing me to give this as a dais to have a good conversation with all my medical friends here in the room offline and online as well. So we are Transcender Services Private Limited with the core purpose that we began our journey is to bring in transformation in those two core verticals, which is education and healthcare. And we all know these are the most two well-deserved verticals, especially when we refer as the Indian context. So we operate predominantly in the three domains, which is education, healthcare, and technology. But yes, for the for the topic of the today, I'm going to restrict myself for when we speak about healthcare as creating manpower and managing the manpower. As I mentioned about this universal healthcare coverage, I think all countries, it's not just India as such, but will need a health workforce. And not only health workforce, I would insist that a robust health workforce that is aligned with two main elements, that is population and the community health needs, both. And also which is capable of adjusting to the growing demand of the healthcare, which is driven by the demographic, socio-economic, political, and most importantly, all of us, what we have learned through the epidemiological needs. Because that's the classic truth that has emerged, that given everything crisis, wave one showed us definitely the shortages of beds and the PPEs. But turnaround time was fast and they were put in place, and all the administration powers really delivered a fantastic job of giving the nice care. Wave two definitely showed us the shortcomings of maybe oxygen cylinders. Again, turnaround time was fastest. We placed that in the right timing. Everything was in control. The pressing issue still remains is the quality, skilled, trained as a workforce. Be it wave one, wave two, expected, unexpected, wave three, there's a question mark. But quality certified healthcare workforce is still remain the concern locally as well as globally. So when we say this manpower, all of us, we know when we say about healthcare manpower crisis, I mean the healthcare manpower we are saying workforce include all occupational engagements what we are talking about, be it from health promotion, disease prevention, treatment, rehabilitation and palliative care, you say volunteers, so on and so forth. On the topic, when we say creating and managing the healthcare workforce, I think I'm going to touch upon this in my rest of 10 minutes as a talk. Three elements, I think, are more important as an aspect to be managed. One is availability. I'm more on saying as a supply side. So though every one of us, we know about WHO numbers as our doctors to patient ratio or a nurses to bed ratio. So I'm not going to get that as a statistics. They're all published numbers. But there where the supply side comes into play as the availability of the workforce at first place. Second is the acceptability of the workforce. So there where we are talking about maybe the gender. When we say nurse, we still get lady in front of our eyes and not how many boys are getting into the nursing profession. So nurse, I mean, I'm saying as a sex, religion, language. Of course, yes, many of the healthcare organizations today are going for NABH, JCI accreditations. So certification, again, as acceptability of the manpower. How many are certified? How many are non-certified as eligible candidates to get into the HCO? If any HCO facility is taking NABH accreditation. And third, and the most important aspect, which I'm going to touch in my dialogue now, is the quality of healthcare workmen. In terms of really the competency mapping, the way it is going, in fact, knowledge and skills. So this is where I'm going to touch upon the presentation as a dialogue. And of course, this is where that SDG third goal, I think one of the panelists earlier was talking about goal number 3, which is all about the healthcare. So let's look at the map first as what is that HR forecast or a workforce estimation by 2022, all the numbers which are prior to 2019 published as of today. So these are the healthcare workforce requirements in real sense. So if you see 2022 vertical bar, I'm not only referring the doctors which are required in 600,000 numbers today, but look at these two bars which are most critical when we are talking about manpower creation and management. All of us which we know, one is the nursing bar, which is the pink bar that we are talking about, 36 lakhs plus. And second, which is not commonly talked about, but which I'm going to focus today more, the top bar, which is of paramedic workforce, the workforce which is really being looked at as a workforce which is required in managing today's healthcare. As I mentioned, the best facility is known by the team that is being carried. And why paramedic? Because technology is another aspect which is creating the more kind of uncertainty or the way the upgradation of the healthcare delivery mechanism is happening. So this is where the paramedic workforce, and this is where I transform, which is connected in that domain. I'm going to take a little bit deep dive when we are talking about paramedic workforce to the tune of 23 lakhs. So how do we create our workforce as a contribution to this entire society, I would put it. So this is our paramedic house, if I say the way the creation is happening, right? The house has got strong foundation, which is based on the value stream. So it's not only the domain skill expertise that we are talking about, we are talking about value stream. Especially when we are saying healthcare, the element which is more critical as a workforce that they exhibit is a compassion element. So this is a kind of ingredient which we have when we are creating as a healthcare workforce for the industry. And above that, which is tile, which is fitted as a plinth level, is our peculiar educational pedagogy. I'm going to explore that a bit more. Once foundation and plinth is strong as a value stream and the educational pedagogy, what you need as a house to build strong is those strong pillars. And this is where the teams that are there to develop this as a workforce, the infrastructure which is best in class, what we are having, and of course, friends who are seated here and online, the industry connect. These three domains, what we are talking about is a quality domain when we are saying that three elements of driving creation as a workforce management. So quality aspect is being taken care of this. Then comes the acceptability, the second element that I spoke about, which is that certification part. And this is where we are creating this as a right workforce to deliver to industry, creating that as a succession path for the career graphing that we are talking, where there is post-graduation, I'm talking about MHA and MPH as the programs, or even giving them as a global opportunity. India is termed as the human capital of the globe, which we are talking about demographic dividend. This is that point which I'm pitching in. And this is where the acceptability, the language skill. Nurses, where do they go predominantly? Only the English-speaking countries, which could be UK, Singapore, New Zealand, or Australia. How many nurses are really going for European countries? Japan, the old country where the workforce is required as the highest level for the caregivers or the home care services. So this is where kind of as a thought process, which I want to share right now as a starting of the pitch, which is quality of the healthcare creation, the acceptability, and the availability. So going a bit on the pedagogy, the first page in our creating the quality healthcare is this 4-stage educational pedagogy. Now, anybody who comes for this paramedic training, for sure, he or she is not from the medical background. So what we insist that this person's foundation has to be strong, how the healthcare industry is being looking at the workforce. So this is where we enforce or create that as a intervention by educating these people in terms of infection control, biomedical waste management, safety and first aid, the CPR, which is a common domain expertise that we give, and personal hygiene. Once he or she clears this as a foundation program, then they are moved to the industry-oriented training program, which is through observership, on-the-job training, and internship. That's something which we create as an overall program management while creating the right manpower for the healthcare. And the acceptability, the certification that we have is on these 4 accrediting bodies, starting with Maharashtra State Skill Development, which is the society, which is a skill board. We have Healthcare Sector Skill Council, which is under NSDC regime. We also have first time innovation, which is created for paramedic technician under UGC regime by bringing in Manipur International University as a certification across the candidature. And I'm very happy to share that we are also as a part of Indian Institute of Public Health to drive specific program, which are caregivers program as a part of delivery to the society. Availability of the candidates, quality, acceptability, and availability. This is what is for Maharashtra, the wings that we have spreaded to give as an available supply of candidates for the healthcare organizations. And it's not only candidates, the critical aspects is under which clinical domains that they are getting trained. So all of us, we have known this kind of paramedic training programs for a couple of years as of now, which is typically phlebotomists, X-ray, CT, MRI technicians, lab technicians, dialysis technologies, OT management. The innovation which we have brought as to give the right delivery mechanism as creating the best-in-class skilled workforce is where we are also supplying or we are creating healthcare as a workforce in the domain when it calls as the neurology sciences. So EEG, EMG, electroencephalography and myography, histotechnologies, cath labs, blood banks, CSSD, medical records, and of course, care for elderly. So it's a bouquet of 12 different streams and modalities where this kind of workforce which gets generated. This is what is the award which we got because of the contribution that we have been doing for last 4 years in creating and managing the manpower for the healthcare industry. We are the winners of Maharashtra Startup Award 2020 and are working very closely with the government. That's the actual real picture of the workforce which has been created and is being put out in the industry as far as a supply. Now, this is as far as general population. We don't stop here because then there has to have a social and community as outreach as our value stream. This is one of the initiatives which we have in this city, in Nagpur, at Karuna State Home. Socially impacted ladies who have been thrown into the sex market and are being forced again and again to get to the same trade. What we have done is we have created the skill lab within the state home, and you can see that program Udne Do, giving the power to their wings to fly and become financially sustainable by creating their skills into care for elderly programs. So after the program certification, this which we are doing with Indian Institute of Public Health as a certifying body, right? So after this program, they are empowered to work with NGOs or government institutionals as a caregivers for elderly people. Yet another, and where we are in Nagpur today is because of IMA, the program which I am holding right now, and tomorrow, where in association with Nagpur Central Prism, working with Mrs. Swati Sathe, we are announcing a program called Parivartan, a real transformation for the prisoners. So this program will be launched tomorrow at Central Jail in Nagpur, Rahate, this metro station. And we'll be launching this program to give this people also an opportunity without getting into their backdrop. Ultimately, they are human. What they will be doing if they are coming out of this and serving their terms when they want to come to the mainstream. So this kind of empowerment as a creating that skill, and which is the dire need is in the healthcare domain, we are treating them, we are giving them training under nursing assistant. Many studies that we did across Maharashtra, not as a real deep dive, but Nagpur Central Jail, Pune Yerawada, and Mumbai Arthur Road, every jail has got hospital facility. The struggle is to create that as a right last mile connectivity to give medical services to the inmates. Because there are doctors at some frequency of visit, and there are no assistants to help doctors to create that as a last connectivity. So we are empowering all jails to create that in-house strength as a manpower and make those jails self-sufficient as a medical services. So that's the whole objective which we are going by when we are running this kind of programs. So this is something which we are saying as a creating as a manpower. Now, when we say as a managing the manpower, now all of us, we know, especially this domain of people, which are non-doctors, I would put it in one domain. Most of the times, these people are hired on a contractual basis and they're put on the resource companies or sourcing companies. The question comes again, the continuity of the manpower. The question comes managing the manpower by taking their labor compliances. These are the pressing issues even for the healthcare organizations. This is just the statistical chart, again, given as a NSDC summary. What it tells us, more than 50% of this workforce is coming under contractual labor. Now, to address this need also in the society, what we have done is, there is a second entity which we announced that we are going by in the market now, which is Transcender Resources Private Limited, a staffing solution to entire healthcare organization. So right from recruitment, selection, payroll management, compliance, and most importantly, continuity of the workforce in the industry. So there is no something called as a gap as to create the last mile connectivity while giving healthcare services to the society and the community by large. This is what is we do as creating. You will find this particular kind of our ad which we have given now in our souvenir, which IMA is going to publish as outcome of this convention. And the last slide when I conclude, this is what partnering opportunities we thought that when we are talking about creating and managing the manpower, how we partner. The central box is the mnemonic or I would say the clip art of various kind of manpower that we are looking at. X-ray technicians, Dr. Suvarna presented very nicely. Now, so many centers are out there. Are all centers, look at our status of the PHC, public healthcare centers, which is a last mile connectivity in the rural areas. How many are really empowered with really qualified and certified good technical workforce, which will do the actual job to reach out to the medical services to the rural areas? This is where we are saying we can have as a partnering approach when it comes to iTransform versus IMA as a group. The boxes where we can create the training, development, certification of the candidates. We can do the staffing needs for any of the healthcare organizations. We can reskill, upskill of the existing workforce as per the technological needs, as per the evolving job roles which are there in the industry. And of course, we can create CME platform. From the IMA platform side, be it a single practitioner doctor or any healthcare organization, the medical facility can be provided in that educational pedagogy, either OJT, on-the-job training, or internship facility. You get the young manpower with no extra cost. If you feel this manpower fits good, create an employment opportunity for those young people. Have subject matter expertise from IMA group. There are few of the IMA groups where the subject matter expertise do come as a visiting faculty for our students to handle and create, again, a skilled manpower and do CME as a platform. I think that's what is the partnering opportunity we are seeing as a collaborative opportunity, working with iTransform and IMA together, addressing the topic of the day, which is creating and managing the manpower. This is what is our mission as we speak on the topic, empower people and trigger self-sustenance for everyone. I'm once again thankful for IMA to give this platform as to share the thought process with the most burning topic today, the most vital topic today, anything and everything as a manpower when it comes to medical services. Thank you very much, and I'm open for any questions.
Thank you, Mr. Samir, for a lucid talk. Very engaging talk, I must say. As an administrator, I represent a JCI accredited facility. I take care of a JCI accredited facility. I went through the list of 12 courses. So one question that I have is, why not a respiratory technician?
Yeah, we do. See, all the 12 courses which are highlighted here are the courses which is recommended by the industry. So if respiratory technician, if industry gives us that as a field that there is, see, we are on the outcome driven as a skill development. So any course that we plug in, we need to ensure that industry has got enough job opportunities to fulfill the training inputs that are given to the candidates. So that becomes as a really fulfillment as a service to the society. So if you recommend, if it's a course where we need to have as a good kind of employment opportunities, of course, that can be plugged in.
During the second wave particularly, we felt the need of respiratory technician. I think
Sure.
that is there is a gap which can be addressed.
Sure, we can look at it.
Excellent talk, Mr. Samir.
Thank you.
I just have a question. This year, government had notified a National Commission for Allied Healthcare, and they will be registered in the NMC register now. So this certification course can they register with that?
Not directly. There is a process where the registration will happen. In fact, just speaking about the point what you said, as an outcome of this new normal, or because of we are also coming out of the COVID situation now, government has taken various initiation where the direct registration happens through the government announced programs. So there is something called as in the state of Maharashtra, there is a Chief Minister's Maharogya Kaushalya Yojana, which is being run at various hospitals. I'm sure many of the hospitals have got direct registration. In fact, I was one of the members to chart out the framework there for CMKVY, what we say. The another initiative which is going for direct registration under that program is something called Pradhan Mantri Mahakaushalya Vikas Yojana 3.0. So these are some initiatives where anybody who is get registered under these programs, when there is a mechanism where it's a machinery where you get directly into the government certification program, while others through the accrediting bodies like what I mentioned about Maharashtra State Skill Society or Healthcare Sector Skill Council, NSDC, these are the body through which the registration can happen.
Thank you so much. Any questions from audience?
So thank you, Mr. Joshi, for
Thank you.
added new perspective. Now I would like to invite our chairpersons, Dr. Gaukar and Dr. Agrawal, to felicitate Mr. Joshi. Now I would like to invite our president, Dr. Devataya sir, our organizing chairperson, Dr. Shehnaz Madam, Dr. Y.S. Deshpande sir, to felicitate our chairpersons, and Dr. Manjusha ma'am as well. Thank you, everyone. Today's last and important topic, cardiopulmonary resuscitation, is an emergency procedure which should be known to each and every person, being a life-saving procedure. Our anesthesia group will enlighten us with the basics of CPR today. For chairing the session, I would like to invite our senior anesthetist and past president, Dr. C.S. Cham, and secretary, Indian Society of Anesthesia, Dr. Sarita Joglekar ma'am.
Hello. Good evening, everybody. First of all, I thank President, Secretary, Organizing Secretary, and Chairman of this conference for inviting us to chair this session, a very important for everybody, and especially this CPR workshop are our basic idea of anesthesiology society. We are doing it every 15 or 20 days to all the non-doctors group, so that everybody should know about the CPR activity, and our aim that a single person should do a CPR and save one life in their lifetime. That's the basic aim. With this, I invite our faculty for this CPR workshop, our own President of Indian Society of Anesthesiologists, Dr. Kiran Vyavhare. Hand over mic to Dr. Kiran.
Thank you, chairpersons, dignitaries present in this gathering, organizing committee members, respected chairpersons, and my dear friends. At the outset, I would like to thank the organizing committee for giving us the opportunity to conduct this CPR workshop. And many people from the audience who are non-medicals, they might be wondering what is the need for this CPR. But let me tell you this, that our motto is that each one should be able to save one life. So everyone in the audience and everyone registered online also, they should be aware of this important life-saving skill, that is the cardiopulmonary resuscitation, or basic life support at least, they should be knowing. So actually we were a little bit not sure whether the audience will be non-medico also or only medicos. So we had thought of COLS, that is compressions only life support, and basic cardiopulmonary life support, that is which all the medicos or the paramedics should know. So what are the objectives? So once you come across an unconscious person or a collapsed victim, then you should be able to demonstrate or assess that the person has had a cardiac arrest. So any person who has collapsed does not mean that he has had a cardiac arrest. It could be because he is just because of fatigue that he has fallen down. So you need to assess whether the person actually has a cardiac arrest. So assessment of the collapse victim, then how to perform the chest compressions and how to give rescue breathing. Then how to place the unconscious person in a recovery position and arrange for the transfer to nearby hospital. Now you can see that around 7 lakh cardiac arrests occur in Europe. And I think the Indian data is that about 4.6% of the people who have cardiac arrest, 60% or 70% of them, they die because of lack of resuscitation facilities. And survival is only 5 to 10%. So that is the need for providing basic life support. And that is the need by every person should know the basic skills of giving a cardiopulmonary resuscitation, or at least a basic life support that should be given. And it has been found that early resuscitation and prompt defibrillation has improved the survival rate to more than 60%. So you can imagine how much it is important. Now today we'll be covering the basic cardiopulmonary life support. And if there are some non-medicos here, then we can also cover the COLS, that is compression only life support, which is taught to the lay public who can help at in the home front and in the peripheries. So now the chain of survival. So what is this chain of survival? You need to recognize, so early recognition. So if a person has fallen unconscious in front of you, you need to recognize that the person has had a cardiac arrest. So how will you do that? So there are certain steps where you should understand or where you can be able to assess whether the person has a cardiac arrest. And you need to activate the team. So you alone cannot do much. So what you need to do is you have to activate the surrounding people. If you are in the hospital, we have the code blue team, where the code blue team is activated, and we give early CPR and early defibrillation. So, and of course, if it is in the periphery, then early transfer to the hospital. So most important is the golden hour, or the first golden 10 minutes, that is the diamond 10 minutes. It is said that it's very important. So these are the various steps we will be covering. First, you need to ensure a safe place, and then whether the person is responsive or unresponsive. So these steps we'll be discussing properly. Now, what is important? Now, first, you need to approach safely. So what does that mean? Approach safely means if the person is a victim of fire or some calamity, some electric shock, so you need to approach safely, because your life is also very important. And you need to check whether where you are giving the CPR is a safe place or not. So this is what the patient has to be shifted to a safe place. Then check response, shout for help, dial 108, check for pulse and breaths, the CAB, and then give compressions and rescue breaths. So we'll come to each slide in details. So the first thing is shift the patient to a safe place. But be careful not to shift in such a way that you are going to create a damage yourself, because might be there is some road traffic accident or some fractures, or the spine is unstable. So you need to be very careful while shifting the patient. Shift the patient to a very safe place where you can give CPR. First, place the person on a flat wooden surface, or any, it should be a flat surface. If the person or the patient is on a bed, then you need to put a hard board below so as to give effective compression. Then what next? So you need to first check whether the person is unconscious or whether the person is, has fainted. So you need to tap on the shoulder, tap gently and ask, are you all right? If the person responds, then you can be sure that he is all right and you can leave that person as you find him. But try to find out what has gone wrong and you need to reassess regularly. First thing you should do is shout for help. So one person who is besides the patient or besides the victim, you need to shout for help and get help from others. The other person will go and dial 108. That is the emergency number for ambulance services. So you need to activate. Suppose you are in the hospital, you activate the code blue team. Or if you are outside in some periphery or somewhere, then you need to get help from others. So 108 is the number where you can get an emergency help. So this is the emergency Maharashtra service number where you can call for AED or the defibrillator emergency equipments. Now, first and foremost, you need to assess whether the person is breathing and whether the person has a carotid pulse. So first, you need to check whether the person is breathing. So how will you check? So this is how you should just assess whether the patient is breathing. Don't get confused with agonal breathing. And then you check for the pulse. So carotid pulse, you should, how do you check? I suppose if all are paramedics or medics, then they will be able to just slide their finger and check there. You can yourself check your carotid pulse. So first check the carotid pulse. This is what we are teaching the paramedics or medical staff. For the lay persons, we tell them not to waste much time in that. You know, if they cannot find the pulse, just for 10 seconds, they can check and then go ahead. So there are three situations. One is that you will find that the patient is breathing normally and there is the carotid pulse. So what do? You don't have to do much. You place the patient in the recovery position and then you reassess and shift the patient to the nearest medical facility. Next is you find that the patient is breathing abnormally, but there is some, the pulse is there, the carotid pulse is there, but he is breathing abnormally. Then what do? You try to provide breaths, rescue breaths, and then again reassess after 2 minutes. Third situation is when there is no breathing and no pulse. So that means the patient has a cardiac arrest and you need to start chest compressions. So how much and how long should you perform the compressions? First is you need to perform 30 chest compressions and 2 rescue breaths. If there are 2 people resuscitating, then one person will provide the chest compression and one will be providing the rescue breaths. Coming to the first situation, now the patient is breathing normally and has a pulse. So probably it could be that the patient has had a fatigue or some giddiness and has fallen down. So then you need to just lift the legs so that whatever blood has gone to the periphery will come back and patient might regain consciousness. If the patient is okay, then you just leave the patient in the recovery position and keep assessing every 2 minutes and shift the patient to the nearest medical facility. This is the recovery position, either right or left we say, but preferably it should be left lateral position. Why is it important? Because whatever the vomitus or whatever food material might be there in the windpipe, it will come out and the airway basically is maintained. So the tongue which falls back on the airway, the obstruction is removed if you keep the patient in the left lateral position or any lateral position. Second situation is that when there is abnormal breathing or there may be no breathing, but carotid pulse is there. That means the heart is pumping, but the breathing is not there, or it could be some abnormal type of breathing. At that moment, what do? You provide 1 breath every 5 seconds and then again reassess after every 2 minutes. So since all I think mostly are the paramedical students, you need to maintain the airway. So you should be able to maintain the airway. So what is the meaning of maintaining the airway? It means getting the tongue out of the obstruction that the tongue is causing. So you just have to lift the jaw, give a thrust and remove the tongue from obstructing the airway. So this is how, what is shown in the picture. You just need to lift the chin so that you see the first picture, it is obstructing, the airway is getting obstructed. As soon as you lift the chin, the airway becomes clear. So that is important. So that means if you maintain the breathing, then it is, the patient will recover fast. Okay, so now the heart is pumping, only the airway you are maintaining. So if you are not able to do that with just the chin lift, then you need to give a head tilt, chin lift, and a jaw thrust. Jaw thrust means we'll be opening the airway. So we'll be demonstrating on the mannequins. We have mannequins and everyone will get a chance to maintain the airway and practice. Now next, open airway. So how do you maintain the airway open? Either like we said, if you don't have any gadgets, you can just open the airway like this and keep it maintained in that manner. If you do have some airways with you, if you have some equipments with you, then you can put an airway just to remove the obstruction as it is shown in the picture. Now, mouth-to-mouth respiration is not recommended because, as you all are aware, because of the COVID pandemic, it is not advised. But just in case it is someone, some near or dear one or person whom you know, then you can provide rescue breaths. But otherwise, it is not recommended now. Next is mask to mouth. So if you cannot give a mouth-to-mouth respiration, then you can give mask to mouth. So you can wear a mask, that patient or victim can wear a mask, and then you can just, with the help of that airway, you can maintain the breathing. Or if you have an ambu bag, then it would be the best thing. You can maintain the airway. One person, it is difficult to maintain and to give ventilation at the same time. So you need two persons so that a proper jaw opening and jaw thrust with the chin lift and maintaining the airway can be easy, and the other person gives the rescue breaths. So how much breath or how much rescue breath that should be given? So it is according to the tidal volume, around 400 to 500 ml. So 7 to 10 ml per kg is the formula. So if an average 50 kg person is there, so 500 ml of tidal volume can be given. Where you see visible rise of chest, you can see the chest rise and fall. Then respiratory rate, how much to be given? So normal breathing, you are all aware, 10 to 12 breaths per minute. So that means you give about half second for respiration and half second for expiration. And necessary volume which is required is you can see visible chest rise. If it is compression only life support, like we had said, we advise it for the lay public and the general population, where you can give only compressions. That means you need not go in for the airway. So why this was done? Because it was realized that this airway maintaining by the general public was very difficult, because either the tongue used to obstruct or there could be some foreign material in the mouth which could cause aspiration. So it was removed from the resuscitation this thing for the lay person. So only compressions. So you can give compressions. So at the same time, when you are giving compression, you are actually compressing the heart in between the chest wall and the spine or the backbone. So, and at the same time, because of that pressure, the air used to come out. The air comes out of the lungs, so that airway also is maintained. So that's why the reason that only compressions help in resuscitating in case of the general public. Third situation, where there is abnormal or no breathing and no cardiac carotid pulse. So that means that person has a cardiac arrest. Now you need to start the chest compressions and provide rescue breaths. Now where to provide? So now all paramedics and medics are there. So I can tell you that you are aware of the xiphoid process, which is present in between your ribs. So two finger above that on the sternum is the place where you should give the cardiac compression. See, this is shown. Exact place where you should give the chest compression and how to give the chest compression. So one hand has to be stretched. Whichever hand is a non-dominant hand has to be stretched like this, and the other hand locks on that so that the chest compressions can be given properly. And there is a proper position. You need to kneel down properly. Your spine should be like in a straight line as shown, and your hands should be straight. You cannot fold your hands or you cannot flex your hands because the proper pressure will not be possible. So how much should be given? Chest compressions about 120 per minute. So that means every second, one compression should be given. 2 compressions should be given. So that is 120 per minute. And how much? About 5 to 6 centimeter should be the chest compression. And there should be a chance for recoil also. So compression and relaxation. And whenever possible, then what happens is one person giving chest compression 120 times per minute, it is very difficult and easily fatigable. So you need to change the CPR operator every 2 minutes. Now, yeah, here they have shown mouth to mouth, which is not recommended, but you can give with the help of a mask or the ambu bag. So 30:2 is the cycle. And continue resuscitation. So how long should you resuscitate? Till the some qualified help arrives or takes over, or the victim starts responding. Or if the victim starts breathing normally or the rescuer becomes exhausted, then you just switch over and continue CPR. Now, if now many places we have the defibrillators, the automatic external defibrillators, where it is very easy to operate and everyone should know how to operate. So you can use the defibrillator wherever possible. Once you open the AED, it will automatically switch on and tell you the instructions. And it will tell us that whether it is shockable or non-shockable rhythm. You need to attach the pads, analyze the rhythm. At that time, when you are shocking, you have to stand clear. So then the AED tells you when to stand clear and it shocks. So that is the shock is delivered. Again, you have to resume CPR. So while in between the CPR, you need not stand clear. I mean, you need to just continue with the CPR. Whenever you are shocking, you need to stand clear and continue with the CPR same 30:2. So then these around 5 cycles of CPR and defibrillation are given. So usually only 3 shocks can be given. Continue with the CPR 30:2 with 2 people and keep the patient in the recovery position when the patient starts breathing normally or has recovered. So this is the protocol. This is the routine protocol what we have gone through. And we have made different charts for this and we have made it available. So you can just go through it. And now we will be demonstrating the CPR. So you can all take your, can practice. Thank you so much for the patient listening.
Thank you, ma'am.
So I request for the mannequins to be brought.
Is there pediatric CPR?
Hello. Pediatric, we will talk while we will be performing the workshop. Basically, the rate remains the same. It is only the depth, like we have to take the age group, some till 12 years. So there we are just decreasing on the depth. The rate ratio, everything remains normal. And if it is a neonatal age group, we are doing by fingers, the resuscitation, either the 2-finger or compressing with the fist. So that we will practically, when we will do hands-on, we will just talk about the pediatric. That becomes easy then.
Hello.
Please come forward, all volunteers, or whoever want to try. I think everyone should try. So please come forward, and they will be teaching you. So you need not, hesitate.
Practicing CPR is very important. If you are not doing it properly, it will harm the patient. So it is very important to properly learn the CPR.
Come. Dilip. Ajay. See the position where you will see. Okay. So in between where you feel the xiphisternum. Okay. And 2 finger above that. It is also known as. Yeah, side la ye tu. Come this side. Just a second. Dilip will first. Dilip and Jitesh.
Hello. 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 I'll show.
ठीक है ना तुम सुन.
ठीक है. You come. हाँ. So
this is how.
अभी फॉर एग्जाम्पल आप रोड से जा रहे हो और रोड के बीच में कोई कोलैप्स हो गया, तो जो सबसे पहला जो स्टेप रहता है कि आप मदद के लिए जा रहे हो, तो पहले आपको उस विक्टिम को सेफ प्लेस पे लेके जाना है. सेफ्टी फर्स्ट. सेफ, तो यू हैव टू मूव द विक्टिम बाय द साइड ऑफ द रोड. तो अभी आपने साइड में ला लिया है. तो फर्स्ट थिंग व्हेन यू टेक द विक्टिम टू सेफ प्लेस, आप उनको फ्लैट सरफेस पे आपको लिटाना है और यू हैव टू चेक फॉर रिस्पॉन्स. तो रिस्पॉन्स के लिए आपको शोल्डर पे टैप करना है. आप ठीक है क्या? आप ठीक है क्या? अभी आपने टैप किया, आपको पता है कि प्रॉब्लम है, तो आप अकेले ही नहीं कर सकते, आपको कॉल फॉर हेल्प करना है. हेल्प हेल्प कॉल 108.
Call 108.
108 को कॉल करना है आपको.
We should call for help.
कॉल फॉर हेल्प 108. इसके बाद आपको यू हैव टू सी फॉर द कैरोटिड पल्स एंड रेस्पिरेशन एट द सेम टाइम.
So where do you see the pulse? You can feel your own pulse. Just check.
फॉर कैरोटिड पल्स आप अपने 3 फिंगर्स से आपका थायराइड कार्टिलेज पाल्पेट करके स्लाइड कीजिए 2 to 3 सेंटीमीटर, और आप यू कैन फील द कैरोटिड पल्स. एंड एट द सेम टाइम आपको चेस्ट पे देखना है कि छाती ऊपर नीचे हो रही है क्या. अगर छाती ऊपर नीचे हो रही है, नॉर्मल रेस्पिरेशन है, तो रेस्पिरेशन प्रेजेंट है कि नहीं ये आप देख सकते हैं. और ये दोनों चीजें आपको 10 सेकंड के अंदर ही देखनी है. तो अभी हम कंसिडर करेंगे कि पेशेंट इज इन कार्डियक अरेस्ट, मींस इन्होंने पल्स भी देखा और रेस्पिरेशन भी देखा, बट देयर इज नो पल्स, नो रेस्पिरेशन. तो इमीडिएटली आपको चेस्ट कंप्रेशन स्टार्ट करना है. ठीक है. तो सबसे पहले कि आपको एक मिनट सबसे पहले कि आपको पोजीशन कैसी करनी है. पोजीशन कैसी करनी है? डोमिनेंट हैंड आपका सामने कीजिए, राइट हैंड.
You can take your hands out.
राइट हैंड.
Keep your dominant hand in front.
यस.
See how he is going to clasp with another hand.
दूसरे हैंड से कीजिए, और आपको ज़िफिस्टर्नम जो रहता है अपना, उसके 2 फिंगर ऊपर जस्ट सेंटर ऑफ द चेस्ट, ना राइट में ना लेफ्ट में, सेंटर पे आपको रखना है.
It is the lower sternum area where we are going to compress. Both of them are taking the position. You can see.
So now you can see the position. Their shoulder is just above the chest of the victim. The wrist joint, the elbow joint, the shoulder joint, they are locked, and the movement will be only on the back joint. So this position will help you to give a very good compression. The compression should be 1/3 of the AP diameter of the chest. that is 5 centimeter. So you have to immediately start the chest compression, 30 compression plus 2 rescue breath. Start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 19, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30. Rescue breath we can give with the help of ambu mask or a pocket mask.
The way he has delivered the compression have a recoil allowed in between. That is 1 up, 2 up, or 1, 2, there is a gap. That effective chest recoil is very important for the effective venous return.
So the rate at which you compress is 100 to 120 compression per minute. That comes, you have to complete 30 compression in 15 to 18 seconds.
Acha, one more thing, important thing is how do you maintain the airway? You should be able to maintain the airway properly. So first is you need to lift the chin, and then you need to open the jaw thrust, and then maintain a seal between the bag and the mask and the mouth.
Yes. So 30 compression, 2 rescue breath, again 30 compression. So one cycle, you have to do 5 30:2 compression and rescue breath. Then at the end of this cycle, we have to again check for the pulse and for the breathing. And if there is no pulse, no breathing, you have to continue the CPR. And you have to change the compressor every 5 cycles, that is 2 minutes. You want to add something? Yes.
Hello.
Yes, sir.
CPR जितना इजी दिखता है इतना इजी नहीं है और इसमें काफी ताकत की भी जरूरत होती है. सिर्फ ताकत की जरूरत होती है, ज्यादा ताकत की जरूरत नहीं होती है. इंजरी करने के चांसेस बहुत रहते हैं.
यस, एक सिंपल सजेशन मैं हमेशा बोलता हूँ कि अगर आज आपने यहाँ पे देखा है और इसको आपको प्रैक्टिस करना है तो आपको डमी तो नहीं मिलने वाले प्रैक्टिस करने के लिए. तो आप घर पे जाके रात को आपका तकिया लीजिए और तकिए के ऊपर 30 कॉम्प्रेशंस कैसे देना है बस ये प्रैक्टिस कीजिए.
Those who are paramedics can keep in their mind that there is one condition called as ideal CPR, where if you think of the ideal CPR, you can give ideal CPR to the patient very well. The norms we maintain that we have to keep the rate of 100 to 120 per minute. We have to allow the recoil. There should not be the interruptions in between. Means you are not changing with the person to give a CPR. One person doing 30:2 and another is coming in and giving 13:2 should be avoided. And the depth should be maintained to 5 centimeters. So if you think of ideal CPR, you can give ideal CPR to the patient.
So for the paramedics, I would like to add why we are doing these chest compression. Actually, the heart has stopped. So what is our job is to continue the circulation. अगर blood supply important organs तक नहीं पहुंचेगा तो वहां पे problem start होगा. इसलिए जब तक हमें मेडिकल फैसिलिटी में पेशेंट शिफ्ट नहीं होता, हमें चेस्ट कंप्रेशन करना है, जिससे कि हार्ट को हमें मैन्युअली पंप करना है, जो कि स्टर्नम और स्पाइन के बीच में हम जब चेस्ट कंप्रेशन देते हैं, तो जब चेस्ट कंप्रेशन देते हैं ब्लड बाहर निकलता है और इंपॉर्टेंट अपने ऑर्गन्स में जाता है. और उसी के साथ रिकॉइल करना बहुत जरूरी है ताकि वी हैव टू रिफिल द हार्ट फॉर द नेक्स्ट पंपिंग. तो वी हैव टू कंप्रेस एंड रिकॉइल, जिससे कि हम मैन्युअली ब्लड पूरे ऑर्गन्स को पहुंचा सके जब तक कि मेडिकल हेल्प ट्रेन्ड मेडिकल हेल्प मिलती नहीं. तो दिस इज द फिजियोलॉजी व्हाई वी आर डूइंग दिस चेस्ट कंप्रेशन.
So what is the purpose of maintaining this? Like he said, the chest compression help the heart to be compressed in between the chest wall and the spine. Okay. And what you are doing is you are propelling the blood from the heart to the brain, so that even if the patient is, many times it is seen even after coming out of the, the patient suffers from brain damage. because the cells, the brain cells can sustain without oxygen only for 5 to 6 minutes. Beyond that, it suffers from damage and neurological outcome is not good. So this is the reason
Madam.
why you should do the chest compression.
Hello.
While saving the patient, you have to save yourself. Don't get too exhausted. Manage your compression.
सबसे हेलो, ये बंद बंद किया क्या कॉलर माइक? हेलो, आपको एल्बो, यू हैव टू लॉक द एल्बो, दैट इज वेरी इंपॉर्टेंट. तभी आपका जो चेस्ट कंप्रेशन रहेगा, जिसको हम बोलते हैं हाई क्वालिटी चेस्ट कंप्रेशन, हाई क्वालिटी सीपीआर. जब तक आप इसके लिए ताकत, अगर आपकी टेक्निक गलत है तो ताकत बहुत ज्यादा लगेगी, अगर टेक्निक सही है तो एनर्जी बहुत कम लगेगी, क्योंकि सीपीआर देने के लिए बहुत एनर्जी लगती है. तो आपको ये रखना बहुत जरूरी है, स्ट्रेट, और आपको दबाना है. और आपको मन में काउंट करना है 1 2 3 4 30 तक.
Next.
और इतना भी जोर से नहीं दबाना है कि अपने रिब्स टूट जाए.
Shout for him. Are you all right?
हेलो,
आपको शोल्डर पे टैप करना है, काका मामा चाचा चाची जो बोलना है बोलिए, जोर से बोलिए.
पेशेंट को ये जरूरी है पूछना कि वो सही में है कि नहीं, नहीं तो आप सीपीआर चालू कर दोगे. हाँ, पेशेंट कॉन्शियस है और आपने सीपीआर चालू कर दिया करके, उस बहुत ही इंपॉर्टेंट चीज है.
And जब आप कैरोटिड पैल्पेट करते
नहीं
हो,
तो बस हमको आ रहा सीपीआर, तो बस गए दौड़ के चालू कर दिए सीपीआर.
जब नेक में कैरोटिड पैल्पेशन करोगे तो ध्यान में रखना है कि बोथ कैरोटिड्स यू आर नॉट गोइंग टू कॉम्प्रेस. एक टाइम एक कैरोटिड, अदरवाइज जिस चीज के लिए न्यूरोलॉजिकल आउटकम के लिए हम कॉम्प्रेशन दे रहे हैं, दैट विल बी हैम्पर्ड. ओके, and the counting should be very slow so that you can have 5 seconds complete for the palpation. Like 101, 102, you can take complete 5 seconds, maximum only 10 seconds. Do not exceed. While palpating the carotid, आप जब carotid palpate कर रहे हो, आप आराम से respiratory movements देख सकते हो. आप close जाते हो patient का, तो you can feel the respiration of the patient also. So that activity will happen simultaneously.
इधर इधर आ जाओ, कम है.
इधर आ जाओ.
लॉक, यस. इधर आ जाओ.
हॉस्पिटल में अगर वाटर बेड पे पेशेंट है तो यू हैव टू कीप अ हार्ड बोर्ड on the back side or a CPR board which is available on the crash cart. Always it is on the crash cart. और अगर एयर बेड है तो you try to take out the air, लीक कर दो उसको,
Yes,
so that
next,
it will be
आइए.
deflated and you can give a effective compression.
सबसे पहले आप ज़िफिस्टर्नम पाल्पेट कीजिए. ज़िफिस्टर्नम, 2 fingers above the ज़िफिस्टर्नम, heel of your dominant hand, second hand lock the first hand, move your shoulders above the चेस्ट ऑफ द विक्टिम और सामने आइए. यस, लॉक कीजिए. 1 2 3 3 जॉइंट्स लॉक. कंप्रेस. 1 2. आपको हाथ ऊपर नहीं उठाना है, हाथ चेस्ट से चिपके रहना चाहिए. स्टार्ट. थोड़ा सा ऊपर लीजिए, आपका पोजीशन गलत है. यस. 1 1 2 3 4 5 6. अभी आपका कंप्रेशन एडिक्वेट नहीं है, आप 5 सेंटीमीटर नहीं जा रहे, आपको और थोड़ा जोर से दबाना पड़ेगा. 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20 21 22 23 24 25 26 27 28 29 30. गुड. ऐसे ही करना है, थोड़ा और कंप्रेस होना चाहिए.
देखने को इजी लगता है, करते वक्त तकलीफ है ना.
आइए. तो आप कैसे चेक करेंगे, रिस्पांस कैसे चेक करेंगे? यस, वेरी गुड, वेरी गुड. हाँ. यस यस, से हेल्प हेल्प, कॉल द एम्बुलेंस. प्लीज आप कोई एम्बुलेंस को फोन कीजिए, यहाँ प्रॉब्लम है. ठीक है. यस यस, यू विल स्टार्ट द स्टर्नम पे. पहले आप जीफी स्टर्नम पाल्पेट करेंगे. 2 फिंगर्स अबाव द जीफी स्टर्नम, अबाव, ऊपर. ठीक है. 2 फिंगर इधर. ठीक है. डोमिनेंट हैंड रखेंगे, दूसरे हैंड से लॉक करेंगे, एल्बो लॉक करेंगे, शोल्डर आपके चेस्ट के ऊपर रहेंगे. एंड स्टार्ट. आराम से. ऐसे तोड़ देंगे आप रिब. रिब नहीं तोड़ना है.
ये ध्यान रहना
आराम से.
चाहिए, अगर हम
1
किसी का फायदा नहीं कर सकते ना, उसका बुरा नहीं करना चाहिए. तो ये बहुत इंपॉर्टेंट चीज है.
ज्यादा फास्ट नहीं, ज्यादा स्लो नहीं. 1 and 2 and 3. हाँ, ऐसे मन में बोलिए. 1 2 3 4 5 6. और थोड़ा जोर से.
जब आप
10.
ब्रेथ्स दे रहे हो
Yes,
पेशेंट को विद
very good.
अम्बू बैग, particularly the paramedics, they should always remember that जब अम्बू से आप दे रहे हो, try to give the breath slowly over the period of
आराम
1
से.
second after a proper seal. So that if you give a more अम्बू का more than half compression करते हो तो बहुत सारी हवा आप पेट में डाल रहे हो.
चलो,
जैसे सर
next.
ने अभी बताया, उसका नुकसान नहीं करना है. ऐसे में जनरली पेशेंट का क्या होता है कि दे आर फुल स्टमक, दे कैन एस्पिरेट. So avoid the compressions. Take a half ambu compression. Ambu bag की capacity is from 1.5 2 liter 2.5. So 500 ml ही हमको tidal volume patient को देना है.
Yes, elbow lock. Yes. Go. 1 2. Yes, good. धीरे धीरे. ओके. ठीक है. आइए नेक्स्ट. बंद केलं एसी. नहीं वैसा नहीं. स्टर्नम इधर. यस.
जब
1
कैरोटिड
2
पैल्पेट
3
करना है
4
आपको सेम
5
साइड पे
6
करना है जिस साइड पे
7
आप हो.
8
Carotid is on
10
both sides.
11
Don't
12
try to go on the
13
other
14
side.
15 16. Slow. 19 20.
And the carotid palpation will
22,
not be proper
23,
if you are going
24,
on the other
25,
side.
26, 27 28 30. ठीक है. गुड. चलो इधर आ जाओ. क्या मैडम 10 सेकंड.
उस तरफ चले जाना. दबा दबा के मार दो. हाँ, बहुत अच्छा. स्टेप का एक फोटो निकालो टैपिंग. एक 2 मिनिट. कोणी राहिले ना. काय झालं स्टेप.
फर्स्ट तुम क्या करोगे? सिचुएशन.
Those who are leaving the hall, please have high tea, which is arranged on the foyer floor. Thank you.
अरे मेरे को मदद ऐसे खड़े रहो, ऐसे कैसे?
मॅडम तिकडे बघा एक.
ये सरिता या साइड पड़ता है. आ जाओ सब लोग. ये इकडे साइड. सच. आ जाओ. मास्क काढायचं का? कोणाचा? बापरे मस्त आहे कॅमेरा मोबाइल.
ये अच्छा सिखाता लेकिन वो
हिंदी में सिखाना चाहिए, मतलब कि इंग्लिश में
हाँ,
थोड़ा सा सिखाना.
yes.
मैंने
हम वहाँ बैठ के बोल भी रहे थे कि तेरा टॉपिक हिंदी में होना चाहिए.
अरे मैंने उनको पूछा
हिंदी
तो
हम
बोले
भी बोल रहे थे पीछे तेरा टॉपिक हिंदी में होना चाहिए.
नहीं मैंने हिंदी में क्या हो गया, बीसीएलएस बोलने से मैं इंग्लिश पे आ गई. नहीं तो सीओएलएस रहता तो मैं हिंदी में बोलने. मैंने बीसीएलएस मेडिकल.
हो ना, हम भी हिंदी में बोल ही रहे थे.
अरे मी हिंदी मध्येच बोलणार होती, तर मग हे लोक म्हणे की आता मेडिकल आहे आणि पॅरामेडिकल आहे, इंग्लिश म्हणजे सीओएलएस असतं. नाही आता हाँ.
नेक्स्ट. उनको दो.
काका उठले.
अरे सभी ट्राई करो हैंड. ऐसा मौका बार बार नहीं आता.
सेम 5 स्टेप्स करो. आता आपण आयसे.
आता आपण हे करू. हे घे.
चेअर देऊन द्या ना. तू खूप बोल.
अरे हो अरे
मैडम के साथ. दरवाजा बंद. लॉक घेऊन. 1, 3, 4 and 5. 5, 6, 7, 8, 9. एक मिनट. सी. एक मिनट. 15, 16, 17, 18, 19. एक मिनट. आप जो कर रहे हैं आपका जो एक मिनट मैडम. आपको चेस्ट 1/3 ऑफ द एपी डायमीटर 5 सेंटीमीटर कम से कम दबना चाहिए, ठीक है, नहीं तो आप हार्ट पंप नहीं कर पाओगे। 1 2 धीरे धीरे धीरे, कहीं नहीं जाना है अपने को, आराम से। हाँ, शोल्डर ओवर द चेस्ट। 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 18 19 20। आपको हेड एंड पे आना पड़ेगा। एक मिनट मिस्टर, आपको इधर आना पड़ेगा, हेड एंड पे आना पड़ेगा। हेलो, चलो गए थे तुम लोग? चला एक फोटो काढो, नहीं होगा। हड्डी खत्म होती है, तो उनके ऊपर
खाना नहीं।
Now it's time
काउंट करना है।
to
1
felicitate our
25
speaker.
26 27 28 29 30। यस, गुड। 1
इसको नहीं, इसको लिफ्ट नहीं किया ना,
इसको चिन लिफ्ट कीजिए,
Please wait for a few
दबाइए।
minutes. Our CPR team.
दो बार।
थोड़ा ऊपर, धीरे धीरे। 1 2 3 4 5 6 7 8 9 10 11 12 13। Okay.
I think the
एक मिनट, रुक
CPR
जाओ।
workshop, the concepts are almost clear now. Nice lecture by Dr. Kiran. Thank you for the hands-on training by our ISA NCB team. I'll hand over the mic to the Master of Ceremony.
On time. अभी भी नहीं। मला वाटलं माझं I would like chairpersons to felicitate Dr. Kiran Vyavare ma'am with a memento.
Everyone, thank you very much. Thank you, all of you all.
Thank you, ma'am. And I would like to ask President and Secretary and Dr. Shainaz ma'am to felicitate our chairpersons, Dr. Cham and Dr. Jogrekar ma'am. इनको दो.
ऐसा ग्रुप मारता एक मिनट एंड करूंगा मैम आ रहा हूँ
Yes, yes.
सर मीटिंग एंड करूंगा